Good morning, everybody. No. That's good. We're doing it. Good morning, everybody. There's a little bit of a delay because we're making sure that we're on. So welcome to the 2021 Palliative Care in Queensland Annual Summit. And this is we're focusing on the state of the state. And to this morning's session, which is looking at what's happening in the sector at a national level. Thank you for coming, and we also thank those who will view this recording later on. My name's Marg Adams, and I'm the President of Palliative Care Queensland, and I'm thrilled to be able to host today's event. And next to me is the fabulous Shyla Mills, who is the CEO of Palliative Care Queensland. We've got a few people behind the scenes, but I won't tell you about those people because I'm on a timeline for that. But we would like to start today's event with an acknowledgement of country. And we have a fabulous woman by the name of Kat Hooper, who is a proud Worimi woman. Kat's a palliative care nurse practitioner who's working at St Vincent Specialist Palliative Care. And Kat's also a member of our Palliative Care Queensland Reconciliation Action Plan working group. So we'd like to, welcome Kat to do the acknowledgement of country, please.
Thank you so much for the honour. Wanya Babalka Babalka. Hello and welcome in the language of the Turrbal and Yagara peoples. I am honoured to be present and grounded today on the ancestral lands and seas of the Turrbal people to the north of the Brisbane River, and likewise I give honour, acknowledgement and respect to the Yagara people, Yuggera people, Malajali people, and also the Quandamuku people in the east. Thank you for allowing me to walk, to learn, to work, to thrive and to lead on your traditional hunting grounds, which you all have been caretakers for many thousands of years. I acknowledge the First Nation Australians as the traditional custodians of this beautiful continent, whose cultures are among the oldest living cultures in human history. I acknowledge and I respect what has been retained and what has been reclaimed, the continuing culture and the contribution that these traditions, these knowledges and these laws have made to the life within our cities and our regions here within our beautiful Queensland. I pay respect to the elders of those communities, and I extend my recognition to their descendants that are present amongst us all today. I would also like to acknowledge my ancestors and those of all of yours that are present here today, and all of what you have gained from their journeying. I acknowledge the injustices by many of our ancestors who moved to new lands or which have contributed to those leaving their homes and lands. And I really think that most importantly, I acknowledge the courage that it takes for all of us present here today, for all of us to move on, to create new lives in places and to extend and our outstretched hand of love, compassion. And I think most importantly, I would also like to consider the compassion and the kindness to the newcomers in our lands. May we all continue with integrity to walk together in new journeys, united to create new songlines, together to share our connections, nurture our countries, our seas and our lands within our magnificent Queensland that we all gather on here today. Thank you and welcome.
Thank you so much, Kat, for that welcome. And now we're going to give you a little bit of an update on Palliative Care Queensland. For those of you who are not really familiar, the Palliative Care Queensland is the peak body and leading charity for palliative care in Queensland. Our organisational priorities are that all Queenslanders are able to live every day until their last, are able to have a dignified death regardless of their illness, age, culture or location, and that they have access to a supportive social network at the end phase of life and have the choice of quality palliative care. We're supported today by our members, partners and the Queensland Government, so we thank you. This annual summit has also been supported by Palcare software company. Palcare is a secure, encrypted web-based patient information management system. So thank you again to our supporters and most importantly to our members. We decided to make today a free event to allow as many people as possible to attend. So we're really thrilled to have the engagement of our usual colleagues and also any new people who are coming along to the summit this year. But we would like to encourage the attendees, if possible, to consider making a tax-deductible donation to PCQ. So it might be your random act of kindness today to contribute, because the work that the organisation does is going to reach many within the state to improving our community's wellbeing. Lastly, we'd like to acknowledge our Palliative Care Queensland board members, Strategic Advisory Committee members, the Palliative Care Queensland members and our staff and volunteers who have through their efforts continued to tirelessly champion the palliative care sector in Queensland. And yes, just a special mention of the hard work that goes on behind the scenes to make this kind of event happen. We also would just like to make mention that there will be opportunities to make comments, and as we go along and give you the updates on how to contribute comments and feedback. I just thought we are all coming from diverse backgrounds and viewpoints, and so we just encourage that when you're making comments that they're respectful. And I can understand that there are a lot of pressures around. So if you're feeling that you want to dig deeper into a conversation, please reach out to us via email. We can update you on how to do that best, and we can chat further. So just recognising this is being recorded, and that those comments will be for all to see. So we just need to be mindful of our conversation etiquette. So we'd love to meet you all in the e-space today. It's a little bit different to our usual face-to-face gatherings, but we're getting there, aren't we? So thank you so much. If you could please write in your chat area where you're watching from today, the session, and also where you are, so what your town or suburb is, or your postcode, and what First Nations lands you're on today. Oh, there's plenty of comments coming through here. Oh, hello. Look at that. Okay, so like I've got my glasses. That's a good thing too, because I can see, which is helpful. So as Kat mentioned, we're on the Jagera Turrbal ends, so it'd be really lovely to know where you're from. And I'm going to I'm not going to kick. I'm going to move over to Shyla and let her give you an update on what's happening with the purpose of this event today. Thank you.
Thank you, Shyla. You're welcome to kick us off.
No kicking. No.
So thank you everyone for coming along today, and to those that are watching this after as well. We really appreciate everyone taking the time. We know how busy the sector is at the moment, so really appreciate everyone focusing on this important area. I thought I'd give a bit of an update about why we do this event and what this is all about. So for those that haven't attended before, the annual summit for Palliative Care Queensland, it's our key event for Palliative Care Queensland in the advocacy and policy space for PCQ. So we've done these for a few years now, and they're really important events that we do in this space. So we aim to bring the palliative care sector together, and in a number of different consultation methods, and to be the collective voice for the sector. So today's event is the State of the State, the annual summit, and we're looking from a national and also a state perspective about how we do that. and everyone has got a key focus to talk about what they've learnt recently, and then what are their priorities moving forward. We then roll into a series of roundtables that are happening in the next month or so, and these are looking at key focus areas. And again, at these roundtables, people identify key focus areas and priorities for the next 12 months as well. Then we do a sector pulse check or a sector poll or survey in the space, and we combine those three activities into a priorities for palliative care publication that is launched during National Palliative Care Week. And that will be for the next 12 months. And really the aim of that is that we're all collectively working together in the same direction. And we're all focusing our resources and our priorities in that same direction over the next 12 months. And then it rolls again. We have another summit at the end of the year and the team get together, theme up everything again, and then we make the next priorities for the sector. So this is a key strategic document for the sector. So we really appreciate everyone coming along and speaking in these sessions, everyone participating through online chats and through round tables and polls, because you are the collective voice, and PCQ's role is really to bring that to the sector and focus on that wherever we can. So a big thank you to everyone for today. I hope that gives a good update of why we're all here and what we're doing with this important information as well. Back to you, Mark.
Thank you. So we have a little bit of an overview of how the time will flow today together, and it's quite structured, and we are on a bit of a timeline. So, you know, for someone like me, I've got some rules and regulations in front of me, which is really helpful. But until about noon, we'll be hearing from some representatives from a number of the national peak bodies and key organisations relevant to palliative care. So this is our national focus session, so really quite specific to the broader context. And we'll be then taking about an hour self-care break. So that can be whatever you want. Food, we've decided you could meditate or just walk around and just reflect on what you've just witnessed in the morning session. We'll be returning then at about 1 o'clock for our state focus session then, and that will run until about 3 o'clock. So it really will be quite an exciting day. Some of our speakers today will present via video and others will present live via Zoom. So we've got some, just realising that this is an online format, and if you get into any difficulties, there are some contact phone numbers and correct? Yeah, just checking. I like this news reading kind of, yes. So each of the speakers have been invited to address 2 key questions: to share their achievements and lessons learned from the past year relevant to Queensland palliative care sector, and to share the top 3 priorities for Queensland palliative care sector for 2022-23. And then after each speaker is presented, I'll introduce the next speaker to present and share their prepared remarks. So following the presentations, we'll invite each of the speakers who are available to participate in our Q&A panel. So we are recording the event, as I mentioned earlier, so we'll share the link with all the registered participants after the break. So if you're feeling like, oh gosh, I wish I would have taken a note, just relax into it because you will have access to this. So without further ado, let's begin our national update. And we would like to start by acknowledging the value of our consumers. This is why we're in the business that we are in, and our carers and the community who are the reason for our sector. So I'm delighted to introduce Anne Curtis, who is the engagement consultant for the specific projects for Health Consumers Queensland. Been on a few road trips with Anne. Haven't we? It's been fabulous. So Anne has a lot of experience in connecting and engaging with our consumer groups. So utilising our Health Consumer Queensland kitchen table discussion methodology, Anne reaches out to health consumers and the grassroots community to enable that interaction and the voices to be heard in the healthcare policy planning and delivery space. Her projects for Queensland Health have included Palliative Care Queensland, have included talking about palliative care, ageing, end-of-life care and dying, high benefit care at end of life, the new Queensland palliative and end-of-life care strategy, yarning about sad news and sorry business toolkit, and the spiritual care and bereavement care guides. Anne has also recently undertaken a series of kitchen table discussions for the government, providing input in the Queensland Palliative Care and end of life care strategy development process for Queensland Health. So that's a very busy lady, but we're thankful for you, Anne. So over to you for your live address.
Good morning, everyone, and thank you for that, Marg. Firstly, I'd like to acknowledge the traditional owners of the lands in which we all meet today, and I'm on Kpmg land, and also pay my respects to elders past, present and emerging, and to all Aboriginal and Torres Strait Islander people joining us today. So with my presentation, if we're ready to start. So yes, on this one, I can only give a state update, but I think whatever I say today is probably relevant on a national level as well. So I've recently just finished on the weekend consulting across the state. So if we could move to our second slide, please. And as Marg was saying, this was in relation to the new palliative and end-of-life care strategy for Queensland. And how I do this is that, as Marg was saying, I use kitchen table discussions, and when we are dealing with our working with our First Nations people, they prefer to call them yarning circles. In this way, this is consumers leading the consultation with community. So we're not in the room, consultants not in the room, health staff not in the room. It's just community in a circle together, and it's something that they absolutely love. And they'll meet in parks, or be in backyards having barbecues, sitting around a dining table. They might go to a library. Wherever they choose to be is where they choose to go. And when they choose the date of their session and the time of their session. So it's very empowering for consumers, and it's a real enabler also for diverse communities, because, you know, if they've got another language, and they can speak in that language with each other and translate back to me what they're saying, and what they would like to input into this process. So this one is one of the yarning circles, kitchen tables, that was actually held in Tambo just a week or so ago. So moving on to the next slide, thank you. So in this process, you know, basically we do this over, yes, could we make the slides full screen, please? I'm just hearing that would be easier for me as well, if that's possible. Move to full screen. It's not showing up as full screen. We're seeing everything. If that's able to be done. Yeah, great. Thank you. So in this process, it was important for Queensland Health that I try and reach out through all of the hospital and health service regions, and also very much to hear from specific groups, Aboriginal and Torres Strait Islander people, of course, those from other cultures, people with complex chronic conditions, those who have been carers for people in palliative care or in palliative care, from pediatric palliative care, so quite broad. And what I managed to achieve was 16 kitchen table discussions and yarning circles. 142 consumers and carers participated in this consultation, and across 14 towns and Brisbane. So a lot of rural and remote voice was heard, which was really valuable. So if we can move to the next slide, please. So I want to focus on a couple of the things that came out of the consultation. So there's only ever 5 questions that we would have in a consultation. And this one was, who is currently supporting people with their palliative care needs from their diagnosis to their bereavement? And, you know, you'll say, well, you know, we know all this, but it's really good to see that community is saying this too, and consumers. So it starts with your carers, your family and your friends, and then you've got your palliative care nurses. And this is their order: nurse navigators, incredibly important role, like HIT nurses, specialists, your doctors, paediatricians, your social workers. They also came up quite a lot, the role of the social worker in palliative care, your allied health staff and your community health nurse. And then you've got your family GP, your pathologist, your local hospital, local pharmacy, home respite care, even funeral homes, the RFDS, ambulance service, aged care facilities respite. And one key one that came out in the Gold Coast consultation was the rural and remote palliative care telehealth service. And you've got your hospices and your Aboriginal medical services, and a real call out there for psychologists and counsellors. So you'll see there's a consistency of message that'll come through in what I'm showing you. Very experienced support teams, really would like to see them integrated services, both tertiary and local. You've got your pastoral care, religious leaders, your local churches, and of course Palliative Care Queensland and Palliative Care Australia and your other support services and organisations. So moving on to the next slide. But some of the key things they did talk about around who's currently supporting people. They did say that some talked about a lack of support, including issues with no community transport, or the fact that they're required to travel long distances, which adds to cost and stress. And that's long distances to see family members, because in smaller towns they can actually have to leave their home and go to another town or city to actually have that care. And for the family member, it's not like they can, as they say, we can't leave work and pop in at lunchtime and go and visit our relative. So talking about hospitals being overcrowded and lack of staff, no access to social workers and no funding available to support palliative care in their own home. So moving on to the next one, and the photos in this, not that there's a lot, but they're actually the sessions that were some of the sessions that were held in this on this one. So in asking who else could be involved supporting people from their diagnosis to bereavement, so they said, look, outreach services from neighbouring towns would be beneficial. So you'll hear that rule on remote voice coming out. Again, that nurse navigator role is so important. Social workers again. Talk about a doula service and how valuable that would actually be, a death doula service, and also the role of volunteers, not just in the hospitals, but actually just in supporting as well. Very much talked about bereavement and bereavement support services and the role of bereavement and even in spiritual care, and the need for grief counsellors. And counselling services for palliative patients, so not just for the families and after, but also that psychological and spiritual level counselling. They talked about translators and the need for translators and those who they called emotional supporters. And again, that cultural and religious leaders are so important, and they call cultural guides and village leaders. Support for those without close family. And that came up quite a bit, those who don't have actual family around them. The need for more aged care services, and that also included respite care within aged care services. And building of community in smaller towns to support those from diagnosis to bereavement. So moving on to the next one. We also asked them if they think there are any barriers to these people supporting them and being involved in their or their loved one's care journey. And from the patients and family perspective, they said not knowing how to access the care that is needed. Fear of not having enough information and getting it wrong, and that came up quite a bit. And being able to communicate effectively and being an effective advocate for their family member. They also wanted to recognise that, you know, as family carers, they are exhausted. And they feel there is a real lack of awareness of impact on carers. And also the distance from family members to give help, that's that transport, that distance thing again keeps coming up. And family dynamics, you know, it's being aware, you know, as you'd be aware that there is not always good family dynamics. They also talked about that the issue, especially around advanced health directives and if they're not in place. And even, you know, not having a power of attorney or a will and the impact that that can have. Being able to afford proper care, especially if being cared at home. And from a First Nations perspective, our people being hard-headed and not being seen as a burden. Isolation and depression during the palliative journey, they felt that this was really, you know, a real issue for you know, needs to be thought about. And from the pediatric palliative care perspective, knowing how to prepare the little ones. And also from that perspective, although parents know their child best, this should not mean that the parent then does everything. So moving on to the next slide, and the quotes have actually come out of that consultation that I've got in here. So again, around rural and remote, it's a lack of service, a lack of qualified professionals in rural areas, lack of communication to community so they understand what's available. What is palliative care? When do you access palliative care? Distance, again, as that barrier, and having a family member in another town or city and not being able to be there for them all the time is such an impact. Again, that lack of transport. And so really they say it's where you live, and accommodation costs when they do have to do that travel. So moving to the next slide. Again, for Aboriginal and Torres Strait Islander families, they said understanding First Nations families and how we roll, understanding our culture. People aren't sensitive and need better ways of talking to us. There was a comment that racism is a barrier. There needs to be a cultural safety, competency and awareness for all. There needs to be an understanding that, as they say, our mob have trauma in their DNA. They need to stop assuming they know us. And also, again, that appropriate cultural support. And moving on again. There's one more. So from that service delivery perspective around those barriers, not having experienced palliative care staff available face-to-face, lack of a local care coordinator, navigator, local palliative care professionals or allied health. So again, that's that rural and remote voice coming out, even in the regional areas, not enough beds or privacy at time of death. In Texas, for example, there was a quote from saying that there are only 2 palliative care beds and there is a couple in both those beds, which means there's nothing for any other family members that have that need right now. Financial cost of out-of-hours care and respite, having those trained staff and funding in the right areas. They really want staff to help facilitate the hard conversations with the patient and the families and knowing how to do that. Again, language barriers, and you know, they were talking about lots of doctors come from other cultures, but they were even speaking about Irish and Scottish and how hard it is to understand the accent sometimes. Lack of information from GPs is a barrier, lack of development of appropriate care plans, and they would actually like to see that the family is also involved with the patient and the staff in actually developing those care plans. Again, talking about stigma and not understanding different traditions or cultural values. A care coordinated team or team to help with transition from treatment to no longer having your child, and more active follow-up, having someone across journey from diagnosis, treatment and bereavement. The amount of feedback I actually received across the 16 kitchen tables discussions was absolutely massive. It was so much, and this is just a very small part of what ended up being an 85-page report to Queensland Health. So yeah, that's just to give you an idea of what people see as the barriers and what matters to them. So thank you for the opportunity to present on that.
Thank you so much, Anne, and we really appreciated the introduction to your session. And what I'd like to do is encourage you all to think about your questions. Noted a couple of hands up, but just due to the fact that we do have quite a busy schedule, we'll address questions at the end. So if you could just type them into the chat, that'd be fantastic. So we'd just like to now introduce Camila Roland, who is the CEO of Palliative Care Australia. And Camila joined Palliative Care Australia in her role in May 2021. So Camila brings a wealth of palliative care experience to her current role, having previously worked in rural palliative care services, allied health and educator roles, so really holistic journey thus far, and having served as the National Program Manager of Palliative Care Australia in the early 2000s. So welcome and thank you for coming, Camila, and we look forward to hearing your session.
Good morning, and thank you for having me on. This is pretty exciting for me. I did actually spend a couple of years living in the Darling Downs, and that's probably one of the small periods of time where I didn't actually work in health and palliative care. But what I did observe was that what I'll talk a little bit later, a bit more about the postcode lottery. So I think that one of the things we know is that palliative care does not necessarily have equitable access all over Australia. And that's something that we've got to focus on. So this has been our year of making our case for investment, and COVID itself has had all sorts of impacts on access to palliative care, and in fact the number of people who are being diagnosed with life-limiting illnesses. So can we go to my next slide, please? Thank you. So really what I want to focus on in this slide is the major milestones we've achieved this year. In 2020, we had Kpmg do a report on the case for investment. And then mid this year, we actually had them complete where the gaps were. So the Kpmg 2 report was actually where are the gaps in information and data? Where are the gaps in understanding what the financial impact is of end-of-life care, and in fact, more specifically, palliative care. And I'll talk a bit more about that in a moment. We've definitely been very involved in the Royal Commission in terms of both advocacy and participating in inquiries. In fact, last week we were involved in one of the Senate committee inquiries into palliative care and aged care and what are some of the gaps. And we noted, in fact, some of the media have picked up some of our statements around the importance of embedding palliative care and aged care. Palliate campaign was all about talking about what palliative care and aged care should look like in an 8-point plan. So then we've had the COVID Palliative Care Working Group, which has continued, and I'll talk about some of the outcomes from that, which were probably a little bit unexpected. We also delivered on the Biennial Oceanic Conference, and we had a record number of people attend, with around 1,050 people attend that conference from all over the Oceanic region. And that was a huge success in terms of people being able to access the different sessions that we delivered online. It wasn't our intention to necessarily have to have it online, because I know how much the palliative care sector really engages with face-to-face. But this year we didn't have a choice. I would also like to acknowledge that I am meeting and I'm presenting from the Ngunnawal country, and I pay my respects to the elders past and present and acknowledge their ongoing contribution to Canberra and its region. And I say that because so much of the work that we deliver is from this region where I'm based, but acknowledging all First Nations people from across Australia. Can we go to the next slide, please? So the Kpmg Report 2, and there's some really interesting findings in that I'm going to speak to. If we can just pop on to the next slide, that will talk about the methodology that Kpmg used. So they really recognised with the first project that palliative care was rising the need was rapidly rising across Australia. And we know from that the demand for palliative care is actually increasing, with the estimated demand in Australia expected to increase by 50% between now and 2035, and then to double by 2050 because of our ageing population primarily. So they did a desktop gathering of evidence. Kpmg spoke to a number of stakeholders, including major bodies like the Australian Institute of Health and Welfare, the federal government, primary health networks, and then they did an analysis of that information. So if you would like to know what their methodology is, that's what they embarked on. Next slide. So this is really, these results just show from their point of view where we have limited data in Australia. And I know that when I speak to our state and territory members, because being a federated country, it's really important we understand what's been able to be collected at a state level as well as a national level, that we have a lot of gaps in our data. There's a lot of work going forward across Australia to have a look at an agenda about how we can fill those data gaps to make our case. Can we go to the next slide, please? So what are the recommendations from that report? The improved reporting and need of provision of home and community care, including the modelling of need, systematic surveying of palliative care needs for residents of aged care facilities, regular updates to the PBS palliative care schedule, annual reporting of advanced care plans, and systematic research into low-value care in hospitals. Those are the primary recommendations. But I do want to go into a bit more detail about what the evidence base said as well. Can we go to the next one? Okay, so there are strong investment economic arguments. And what they're basically saying is that we have room for improvement, but we are seen internationally as a leader in palliative care. So that's really interesting. We have a lot of unmet need and a growing demand for palliative care, which I spoke to. There's good, strong moral arguments for continuing investment, and of course, good economic ones. The arguments that were most compelling is when we talk about meeting unmet need and how we do that. There's also, in addition to the Kpmg report, there's actually been anecdotal information come through some of our national working groups about the increase in demand for palliative care from people who weren't diagnosed during COVID periods of lockdown. And that's coming from all across Australia. So even those states and territories where the cases of COVID were low, the number of people who didn't go and see their GPs, their specialists for diagnosis and treatment rose considerably. And we are aware now that we are hearing that there's been a 60% increase in referrals for palliative care since COVID hit us in March, April 2020. So that's a really big impact. And we're expecting that that will continue for at least 2 more years. So if you think about people just in the last few months who haven't accessed diagnosis, but their symptoms have been exacerbated, they present to ED in the coming months, it's too late in some cases for treatment, but we're expecting those cases to grow all across Australia. Can we go to the next slide, please? So we've continued to provide advice to the Australian government, and we're involved in a few different committees that talks about particularly the way that COVID is being treated. We provide advice on the impact of COVID patients on palliative care services, the impact on people in the community not coming in to access hospital and treatment services, requiring more in-home support and community-based care. We've very much reported about the workforce fatigue. And it's not just about clinicians working in ICU, it's also about clinicians in palliative care being taken offline to go and run things like vaccination clinics and work in other areas of hospitals. So we found that to be a very interesting trend that was emerging. And of course, we talked about presenting at hospital as well. Next slide, please. So just quickly, I have already mentioned that we have been involved in the review into the aged care quality standards of focus on palliative care. There's going to be a new National Elders Council, and we've nominated 4 people with palliative care, both lived experience as well as expertise to go on that council. Next slide, please. So I will just basically pop that up so you can see what we've been working on in terms of the implementation of the National Palliative Care Strategy. But essentially, there are still 17 national palliative care projects going forward that we're working on. And one of those key ones is around how the Greater Choices Project and how that's being rolled out across Australia. And that's that interaction between primary health and specialist palliative care. Can we have the next slide, please? Also to mention that we have the first paediatric palliative care national plan being developed ever in the Australian history of palliative care. So we're really excited about that. And we expect that plan to be ready by the end of this year to roll out a series of activities on what paediatric palliative care will look like across Australia into the future. Can we have the next slide, please? Next slide. Thanks. Really importantly, we've had a yarning circle help us to provide input into the national palliative care projects, but we're now leveraging and consulting with people in the yarning circle about the potential to develop an Aboriginal and Torres Strait Islander national palliative care strategy. And that will take a few years to develop, and it's a key element of our new strategic plan from 2022. So at this stage, we're just talking with people about what should the governance groups look like, what should be the methodology we use in terms of yarning circles, etc., to engage with people to develop this Aboriginal and Torres Strait Islander-led strategy, but supported by Palliative Care Australia. Can we have the next one, please? Look, these are just to give you information, and you can definitely have my slides, but it's really just to say the More Than You Think campaign is probably one of the most successful campaigns ever in terms of getting community connection into what is palliative care. And we've definitely raised the awareness about what is palliative care. So just for your information, nationally, it's now expected that 76% of people across our community understand what palliative care is, which is an incredible increase in about 12 years from what was 36% to now 76%. Next slide, please. So we've achieved promoting our case for investment, and of course we've got the federal election coming up, which we anticipate in May. We will start rolling out our national election campaign in this next month, and we're just putting together the final election documents around that. And that will have a number of asks that have come out of our consultations and the Kpmg report. We'll continue to engage in the national reforms for aged care and embedding palliative care in aged care, and we've done a lot of work on that already. And we're going to be bold in our policy leadership in our next strategic plan. And I think that that's a move slightly forward in terms of advocating more strongly about the voice of consumers and the voice of practitioners and clinicians. Can we go to the next slide, please? So what are we going to advocate on? We've just about finalised a 5-year roadmap, but I've constantly talked about making palliative care core business and aged care this morning. We need to have more data and research, and having an agenda and national strategy around research, supporting the palliative care workforce, including both the specialist palliative care workforce and the workforce in primary care. Investment in dedicated palliative care services, because we have this postcode lottery happening at the moment, as Kpmg have identified. We're providing more support to carers so they can care for their loved ones. We're going to fund, we're looking for funding actually, but we're hoping to fund the Pediatric Palliative Care Action Plan activities. And also we'll actually look at investment awareness campaigns to raise community awareness about death, dying, and what palliative care should be. So I'm going to leave you with a few statistics. I think if we go to that last slide, I think that might be my last one, and I know I'm getting the wind up signal. So those are all the things that we're going to be doing as part of our new strategic plan. But I want to leave you with a few stats. Only 1 in 6 public hospitals in Australia has a specialist palliative care inpatient unit. There's a large variation in access to palliative care in hospitals. For example, in Victoria, there are 12.2 palliative care public hospitalisations per 10,000 population, but in New South Wales, the rate is 21.1 per 10,000 population. So this just shows you the variation. We're expecting the number of people needing to access palliative care to double by 2050. And we also are concerned about the impact that COVID has had on demand for people with life-limiting illnesses in the next few years. So a lot of our arguments around our federal election campaign will be centred on those issues. Thank you very much.
Oh, okay. Oh, I'm unmuted. Thank you, Camila. That was fantastic. And we really appreciate your input and looking forward to the Q&A section. And I have been reminded that if you do want to make a comment, if you could go and make your comments in the Q&A section, because I'm making work. Rookie error. So without further ado, I'd like to introduce our next speaker, Professor Leroy William. And Leroy is the president of Australian New Zealand Society of Palliative Medicine, fondly known as ANZPAM. Leroy has been a palliative medicine specialist since 2009 and is based in Melbourne. He's currently the clinical director of the supportive palliative care service of Eastern Health, with adjunct positions at the Eastern Health Clinical School of Monash University and Public Health Palliative Care Unit at La Trobe University. Welcome, Leroy, and thank you for your presentation.
Thanks very much. Sorry I was a bit late joining, and I haven't got any slides, so I'm just going to talk to the 3 points that we were asked to consider from an ANZPAM perspective. And I also want to just say I'm now the past president of ANZPAM, having handed over the baton to the illustrious Christine Mott, who I'm sure many of you know from Queensland already. So, and she's in Birmingham at the moment, and so I'm standing in for her in this role. it's been a tumultuous year for ANSPAM in one way, shape or another, not only because of COVID and voluntary assisted dying that we've been having to deal with, but also, you know, we had a new CEO and then a whole new team of secretariat members that came along with the change in leadership. And so finding our sort of place was important, but when we looked at our strategic plan for the next few years, we reflected on the previous strategic plan, and this leads to the first thing that I think we found as a lesson, which was our need to focus our energies a little bit more. We were very broad in our ambition in our first strategic plan, and I think that perhaps if it wasn't for COVID and voluntary assisted dying, maybe we would have been okay. But I think with those two things on board, it really did run the secretariat rugged a little bit. So I think, you know, that's something for us to consider, what we can achieve with our resources. The next thing is remaining united in our cause, and I think I've spoken to this in terms of voluntary assisted dying, in that when Cicely Saunders was on the oncology wards in the 1950s, and she was seeing the patients and families there tucked away in sometimes rooms with no windows, she made a choice to sort of care for those people and rally people to help start a movement, which is the modern hospice movement. And we had a choice at that point to do one thing or another. And I think it would have been very easy if you put yourself in those shoes, when you don't have the resources that we have and the skills we have now, to maybe think that ending someone's life who was suffering so much would have been easy to do. That wasn't what she did, and that wasn't what the profession did as well. So I think that remaining united in our cause is something that's going to be very important for us going forward, and making sure we draw the line and the sand that clearly says what we do and what voluntary assisted dying is. And then I think the third thing that I think we've learned is the importance of supporting each other. That's not only supporting each other locally, but it's also statewide, nationally, internationally, even with our colleagues in Aotearoa, New Zealand, that we also had to help with their legislation changes that they've had recently. So those were the three kind of lessons. It was lessons or achievements, so I'm not going to talk about achievements, but those are the three lessons I think that were very significant to me. And in terms of priorities going forward, I think we've talked about equitable access, and we've mentioned this in our strategic plan for the next few years. So we've got 4 areas, and equitable geographic access is one of them, and that's very pertinent to Queensland. But I think equitable access in general, we've already heard about the postcode lottery. We need to do better, and we've got also the means of doing that with telemedicine. I think again Queensland's led the way in terms of using telemedicine very well. Workforce planning was another priority that I think we need to address, and I think everyone's looking at workforce planning from all the specialties, but certainly we recognise as a society that not only represents specialists in palliative care, but also generalists in palliative care as well. Anyone who's got a palliative care interest, who's a medical practitioner basically, and sometimes even not medical practitioner, is a medical student as well. So we have a broad base of membership that we need to empower, but I think we also need to think about what we need in our societies in terms of the knowledge of palliative care in the workforce that we have, and that sort of leads into education. And then the third priority, I think, is also advocacy, and advocacy involves collaboration in order for us to support more people, but advocacy in policy and funding, and obviously advocacy as well for certain other groups in our society. So aged care, as Camila's talked about, the rising population of people that will have dementia, and how we can advocate for all those groups in the best possible way with our connections. And I think we've been working very closely with PCA, in fact, so closely that we plan to move into their offices. And that will be, I'm sure, a great move for us to align our agendas and maybe bring on board other disciplines in the sector. So under the same banner with PCO, working together for advocacy for palliative care across the country. So those are the things that I've reflected on from an ANSPAM perspective. It's certainly been an honor to serve as president, but I won't be lying if I said I was relieved to hand over to Christine. But we will be working close together. I'm still on the council, and I'll be offering my support to Christine as much as she needs it, but she's more than capable. You've trained her well. Thanks very much.
Thank you so much, Leroy. And I'd like to just acknowledge Christine and welcome her when, in fact, you have time to watch this back, Christine. And thank you for your contributions in that leadership role as President, Leroy, and we look forward to seeing you around. Of course, I think you've got a few things on your plate, haven't you? Leroy, thank you. Now, we're moving on now to our next speaker, Dr. Claudia Verdin. And Claudia is representing Palliative Care Nurses Australia. So Claudia is an experienced specialist palliative care nurse interested in enabling optimal care for people with advanced serious illness, regardless of their care setting. Claudia's passion for excellence in palliative care has seen her focus on a varied clinical experiences combined with research and improvement work to inform service change. Claudia has recently completed her doctoral studies. Congratulations, Claudia. That is no mean feat. And her study focused on enabling optimal inpatient palliative care. And her current, she also currently is a senior research fellow for the Faculty of Health at the Queensland University of Technology. So we have a lot of high achievers that's sitting in this room. So really looking forward to your presentation, Claudia. So we'll take it away.
Thank you very much. Thanks, Marg. And I think I do have some slides, so I don't know if they're coming through, or I can share my screen if that's helpful. Here they come. Okay, so thank you. First of all, thank you for allowing us some time to speak today on behalf of Palliative Care Nurses Australia. I'll probably go through quite a few slides quite quickly, so I'll get you just to keep clicking them over if that's okay. And I'd particularly also like to acknowledge the country that I'm sitting in at the moment. It's the Turrbal and the Yagara country, and acknowledge the First Nations owners of the lands where I am. I'm currently at home, working from home at a Camp Hill in Brisbane. And I really recognise that these lands have always been really places of teaching, research and learning. So today I'm talking to you, as I say, on behalf of Palliative Care Nurses Australia. And if we just go to the next slide, I'd just like to acknowledge the full committee who are working with us within this organisation. So the president is Janine Harlem, the vice president is Josh Cohen. I'm in the secretarial role, and we also have a treasurer called Katie Long, and our committee members who are also supporting all of this work include Julianne Brisbane, Katrina Rakosh, Anna Nicholas, Libby Miller, Rebecca Palmer and Nikki Johnston. And we have a great secretariat as well, who you will no doubt see emails from time to time, including Vicky Ann and Natalie. And I really hear Leroy's pain. It's quite tricky. I mean, our secretariat hold us together in so many ways, and we're very, very grateful for their support. So if we just move to the next slide. Palliative Care Nurses Australia, our vision is very focused on nursing, and as you just heard Leroy talking about ANSPAM and their focus being more around medical practitioners across generalist and specialist roles, we're similar but in the nursing perspective. So our vision is to promote excellence in palliative care nursing for our community through leadership, representation and professional support. And we aim to foster the sustainability of the nursing workforce in palliative care, to promote the professional development of nurses, to provide opportunities for collaboration, to facilitate knowledge, research, education and policy in palliative care and really promote palliative care nursing in a changing environment. And again, working from some comments Leroy made, that changing environment in relation to voluntary assisted dying is a really important consideration, and it's an important time for us, as Leroy has mentioned, to be really firm on what palliative care nursing is and how we can best contribute. So if we just move to the next slide. When I was thinking about the top 3 achievements for Palliative Care Nurses Australia across the last year or so, we really sort of thought there were 3 main areas. One, we do a lot of work around membership support. The second area is about education. And the third, which is increasingly important, is really around sector representation, providing input on key committees and providing relevant submissions to different inquiries. I'll give a little bit of detail about each of these 3 areas. So if we just move to the next slide, in terms of membership support, we've got 490 members, and we do have members from all states and territories across Australia, and that includes 102 members from Queensland. We maintain a fairly dynamic website where we have Nat and Vicky Ann helping us to keep that to be quite responsive with new material going in there very regularly. We have monthly newsletters. We try to have quite a strong social media presence. We also have access to a journal subscription for all of our members, and we recently changed that from the International Journal of Palliative Nursing to the Journal of Palliative Medicine. We have ongoingly grappled with providing a mentorship program, and we've struggled to get that off the ground just in terms of our own resourcing, I guess, but we've got some refinements underway in relation to that program, and we're really hoping to relaunch something. So watch this space for that area. And we're ongoingly organisational members of the European Association of Palliative Care, and that's provided a really nice support for our membership around discounts and international collaborations and weekly updates on current evidence as well. If we just move to the next slide, in terms of workforce education, there's really 2 key areas, and one is a program of webinars that we're running, and you can see 4 webinars that we have run on the left of your screen there. And they've been really well attended, increasingly so often 70 or 80 attendees who are really quite involved in asking questions throughout those sessions. So we've been really delighted with that and keen to continue that. And we've really, we have a biannual conference. We had to run it virtually in 2020, and we've chosen to do so again in 2022. And as Camila noted earlier, we're really hoping then we'll be right to go back to face, as we do miss that sort of networking component. But give a bit of a plug for our upcoming conference. The theme is Exploring New Dimensions, the Future of Palliative Care Nursing. And our key focus areas are really around nurses leading change, innovations in palliative care for older Australians, updates on the National Palliative Care Policy work, integrated palliative care in practice, and how can we embrace digital health within palliative care. So we would love to see your contributions to that program, and our abstracts are due in early February. And early bird registration early next year as well. So we really will continue to give you information about that conference over the next few months. And if we just move to the next slide, the sector representation has also been really important and has been a large focus of work that we've been involved with over the last 12 months. I won't read through all of those committees, but you can see there's a number of committees that we're regularly representing palliative care nursing perspectives on, and we have members of the actual committee working with all of those organisations, but we also work with our members to represent at these as well. So it's been great to give a voice to senior nurses across the sector to come and join with us in PCNA and contribute to that representation role. And then on the next slide, you'll see that we actually have also I've just put a few of the submissions that we've been involved with on the slide there, but that's again an important piece of work that Palliative Care Nurses Australia is doing. And I guess for me, having been involved in a number of those submissions and representations, I'm ongoingly delighted at the fact that people do want to understand about palliative care. They do want to understand about the nursing role within that and how we can contribute, and amplifying that voice, I think, is really an important aspect of the work that we're doing. So if we just move to the next slide, the lessons that we've learned with felt were really around these three areas. The first one being about amplifying patient and family voices. So the real core of why we're here. It was fantastic to hear Anne's presentation to start today, where so much of what we're trying to, I guess, amplify aligns with many of the findings she was finding as well. The second was around investing in our nursing workforce, and the third really was around collaboration. So really, firstly, we wanted to note the importance of amplifying the nursing voice throughout the representation and the submission work that we're doing. We've really seen it's very powerful, and it really does retain a strong focus on the patient and family experience and outcomes from care provision. Secondly, we have really learned about the opportunities to provide responsive education within a virtual format, with the importance of this addressing a range of needs. So that sometimes is very explicit clinical skill development. So for example, earlier this year, a new syringe driver was launched, and we were able to run a series of webinars that specifically worked with launching that new syringe driver and giving very specific clinical skills around that. But also we're able to run responsive webinars that are about developing nursing for the future, harnessing and supporting innovation, and really enabling an update around key evidence changes. And we really see that about investing in our nursing workforce. And like Leroy said, we within our membership have quite a diverse range of nurses that are our members, and we are delighted that that's the case. So nurses that are working in a variance of roles, from enrolled nursing to registered nursing to clinical nurse consultants, educators, and certainly nurse practitioners as well. And we also have associate members who are perhaps student nurses, Aboriginal health workers and the like. So we really encourage all of those members and try to provide responsive education for all. And certainly we've also learned that collaboration is key for two reasons. I think it helps us as an organisation that doesn't have a lot of resource to be more efficient. But I think it's also providing a more powerful and consistent message to jurisdictional and national bodies where there's an important statement to be made. And we've been working really closely and with Palliative Care Australia, the Australian Nursing and Midwifery Federation, and the Palliative Care Australia member orgs such as Palliative Care Queensland. And we really do believe that together we are stronger in the messaging that we're trying to provide. So if we just move to the last slide, the top three priorities for palliative care in Queensland from our perspective when we were considering this were centred around, firstly, the Queensland Palliative and End-of-Life Care Strategy, really enabling an opportunity to ensure an ongoing focus on enabling nursing and nurses to work to their full potentials and scopes of practice, and really thinking about this through the whole variants of nursing roles that we have: enrolled nurses, registered nurses, nurse practitioners, clinical nurse consultants, educators. All of us that are working in this space are valued, and I feel that there's a real opportunity to harness that workforce to better support people with palliative care needs. Secondly, we really felt that it would be great to have a priority around resourcing and empowering nurse leaders to innovate, to really enable care that aligns with patient and family noted areas of importance, and really look at supporting nurse-led models of care, including the evolving nurse practitioner role and all that can bring to our sector. And really removing some of the barriers that are stifling some of that. We really feel we could be harnessed and empowered to do so much, given that we're a huge workforce available 24/7, highly skilled and really available across all locations of care, both in terms of metropolitan, rural and remote, but also across community, aged care, acute care, prisons, and really everywhere that patients are living. And the third priority was really better understanding quality of care provision in greater depth to really inform development and improvement, and really ensuring that doesn't only look to structural data measurement, so around activity, but ensuring patient and family voices are ongoingly heard and are really the core for driving care improvement and care models of care provision. So the final slide is just to say thank you. I'm very happy to have any questions. And again, another plug for our conference early next year. We would love to see you there. Thank you.
Claudia, thank you so much. That's fantastic. And I'm sure if people have, there's some really interesting pieces of information coming through from all of our speakers thus far. So please make sure you put your comments in the Q&A section, and our behind the scenes crew are nodding their heads that these comments are coming in, which is really fantastic. I would like to now move on to introduce our next speaker and guest, Alison Gundry. And Alison is currently Allied Health Clinical Lead in Pediatric Palliative Care Service Project, and it's fabulous to have representation from our allied health colleagues. It's really, I like to call it out whenever possible. So Alison, thank you for representing allied health and increasing visibility of the value of and contributions of allied health in palliative care. So the Pediatric Palliative Care Service Project is part of a statewide paediatric palliative care service at the Children's Health in Queensland. And Alison has worked as a senior social worker in paediatric settings and across the disability sector, as well as spending 8 years at the bereavement coordinator in the paediatric palliative care team. So today, Alison attends as the Queensland Network co-convener of Palliative Care Social Work Australia, which is PCSWA, and a role that she has shared with Kim Sutherland since October 2020. So a warm welcome, Alison, and thank you for your presentation.
Thank you very much. So thanks, Marg, Shyla, Palliative Care Queensland, the fellow panelists who I think Marg made the comment that it's an impressive cohort. It's certainly a brains trust, and guests joining us virtually. So a very warm welcome. So Palliative Care Social Work Australia, or PCSWA, is grateful for the opportunity in offering background to this relatively new but growing incorporation of social workers, and also in shaping palliative and end-of-life care priorities in Queensland across the coming years. So I attend today as the Queensland co-convener of PCSWA, acknowledging the PCSWA chairperson, Dr. Philippa Blackburn, and on a national level, the executive leadership team representing all states, as well as the specialist consultants who lead professional education and support across a myriad of priority areas. So to Kim Sutherland, a trusty sidekick who's not here today, but who shares the role of co-convener for the Queensland Network. And simply put, we are a national association of social workers from a range of different areas and places. And so however, before unpacking further who we are, what we've done and what there is still to do. So I'd like to pause with deliberate intent to offer an acknowledgement and just ask for the next slide, please. So yes, Palliative Care Social Work Australia, PCSWA, acknowledge the Aboriginal and Torres Strait Islander peoples, the first Australians. We acknowledge their ongoing connection to land, sea and community. We acknowledge that the story and spirit of Aboriginal nations are written in the landscape of this country, and we pay respects to elders past, present and future, for they hold the memories, traditions and values which deepen and enrich the life of this land and our communities and nations. So can I ask for the next slide, please? So yeah, we are an association of social workers who provide or have an interest in palliative and end-of-life care and bereavement. It was lovely to begin this conversation today with Anne's reflections on consumers' voices and hear the value that they shared in that social work level of support or layer of support. So, social work in palliative and end-of-life care and bereavement support. So what does that look like? People and their carers or families will often encounter and receive support from social workers in a range of different roles and settings. So PCSWA membership represents social workers in both generalist and specialist settings, including palliative care services, hospitals, aged care, mental health, disability, education, and other areas such as legal, housing, financial services. The association launched actually only in May 2020. It was part of a Palliative Care Week, an event. And it was as part of the launch that the aim was to increase awareness of the breadth and depth of the social work role and what we do in supporting patients, their carers, families, our teams and services. We showcase vignettes, and these can be viewed on the PC SWA website with the intention to raise awareness. And these were in line with the theme of the Palliative Care Week. We've already heard how successful that one is, that it is more than you think. This is especially so in relation to the support that social workers provide. So also released at the launch of PC SWA were the social work practice standards. And these standards provide a framework that outlines the knowledge, skills, and abilities required of social workers to provide competent and effective palliative and end-of-life care and bereavement support. Fundamentally, the end point is to provide high quality care to people, their carers, and families. So PC SWA is committed to enhancing the provision of high quality and holistic, person-centered, family-focused, and community-oriented care. I think the synergy of social work's core values and how palliative care operates and its guiding principles, there is a lovely synergy. The association recognises that health and social care disparities are caused by a range of factors which impact on quality of life, access to, and the experiences of palliative, end-of-life and bereavement care. PC SWA has a fundamental commitment to social justice and human rights, which positions the profession as a leader with expertise in analysing, advocating for and implementing system and policy change around health and social inequities. I think we've heard today from the nursing and medical colleagues that we're amongst friends here, aren't we, in terms of being on the same page with what we're hoping for the outcomes to be for the families that we walk alongside and care for, and as a system. Can I ask for my next slide, please? So this is who we are. So we currently have close to 240 members since forming in May last year. So there's a real appetite for coming together as a community of social workers in palliative care. And so far, around 60% of the membership work in specialist palliative care settings, around 25% work in hospitals or other health settings. We also have a growing membership from a broad range of other areas, including private practice and social work students, so that those emerging practitioners, it's sort of getting in early, has a great appeal. Queensland is well represented, go Queensland, in terms of numbers, location of practice, with members across the state and diversity of work setting. And members are employed by public and private hospitals, hospices, NGOs, and in private practice. We have active state PC SWA networks in Queensland, Victoria, and New South Wales, the ACT, and these networks are coordinated by co-conveners. So here in Queensland, Kim and myself, and secretaries. Sorry, I meant to mention Katrina Gordon, who acts in that role for us here. These networks, we hope to expand the state and territory-based networks further in the future. So can I have my next slide, please? So this is, I suppose, a snapshot of the executive team of PC SWA, and it's the organisational structure with guidance from the executive team and social work consultants, and they hold priority portfolios and working collaboratively with the states to kind of bring together those priorities. The focus areas are informed by the needs of the state membership, And there's this easy flow of ideas going from a bottom up and a top down in terms of the organizational structure. So it's responsive, it's agile, and it works well. Could I have the next slide? Thanks. So yeah, we were asked to kind of look at, you know, what we've been doing since we formed, which I think we've been pretty busy. I think everyone's been pretty busy, which is, I suppose, keeps us out of trouble. As already mentioned, the development, implementation, and the evolving nature of national standards in social work aligns with the priority 4 of PCQ in building capacity in a palliative care workforce. It's difficult to advocate for what you do and how you value add unless there's clearly articulated and refined standards of care. So that's been a big part of the social PC-SWA's work. PC-SWA has representation in leadership roles and forums at state and national groups, and comes together to respond to relevant inquiries and consultations, again aligning with any number of the priorities articulated by PCQ over the past year. And I think, Claudia, you did a great job of just showcasing there is a lot happening in palliative care, and you know, you have to show up really and lean into it. So equally, I think we've been represented on any number of those forums as well. So likewise with PCQ Priority 5, we have co-founded an international association, the World Hospice and Palliative Care Social Work, World Hospice and Palliative Care Social Work Association. Although this is in its early stages, discussions on collaborative activities provides a promising future and will further contribute to the development of our members. In addition to the state networks, we've established a network for social workers undertaking further studies in postgraduate research degrees via a higher degree research network. So, and that's an important part of the picture too, in terms of understanding what, you know, the needs of the population that we have and trying to quantify them. So the work of PC-SWA has seen workforce education with a focus on young people, as well as the implementation of the VAD legislation. And again, these achievements, or what we've been doing, is certainly synergy with the focus for Palcare Queensland this past year. So just one more slide from me, please. So where to next? Yes, the work's yet to be done, or is still ongoing, isn't it? So, so in our work, we refer often to the guiding principles for palliative care Queensland. I think it's such a helpful snapshot. I think it's a colourful as well, so perhaps that's what attracts me. And it's a wholly usable snapshot of what we are and should continue to be striving to achieve. So continuing consultation into the implementation of VAD legislation, I feel PC-SWA social workers generally have a voice or perspective in that space. The PC-SWA representation on the Queensland Palliative Care Clinical Network, and bringing that social work practice framework to these considerations. So I mention or highlight care for the carer, and I do that in accounting for both families and loved ones providing care, as well as nurturing the workforce for professional carers. And I think there's a role here for PC-SWA in terms of facilitating opportunities for family representatives to have their voices and experiences heard. Supporting Queensland palliative care social workers. So we're actually, a bit like Claudia was saying, trying to develop a peer mentor program for practitioners to work alongside each other. So we're already, that's providing an opportunity potentially for reflective practice places, so that practitioners can come together. And the current focus on delivering bereavement support to families after death of the loved one, a comprehensive response is needed for most, for some, and for a few. And an overarching bereavement framework suggests that all people who experience the death of a loved one have some level of need, and this support can and should be accessed from within the community, using a broad definition of community to include family and extended networks, health services, NGOs, charitable organisations and the like. There is always more to be done, and Palliative Care Social Work Australia leadership and members at local, state and national levels are ready, willing and able to show up and then lean into shaping and delivering palliative and end-of-life care and bereavement support for families accessing palliative care services in Queensland. And a priority for PCSWA is to continue to raise the profile of social work, and we welcome partnerships and affiliations. And if you'd like more information about PCSWA, you can have a look at the website. And if there's any social workers tuning in today who aren't members, you can go online and join. Thanks for that.
Oh, I'm unmuted now. Yeah, I peaked too soon. Alison, thank you so much. I was going to do that bit of a punt, and I will say go Queensland, 33%. You may have, we might take to 35%, you never know, after they joined Palliative Care Queensland. So yeah, anyway, I was sorry. Now I have, this is my pleasure again, I've got all these pleasures this morning to introduce the wonderful Associate Professor Anthony Herbert, who, by the way, is fondly known as my wingman, or the Vice President of Palliative Care Queensland. And Anthony is the Director of Pediatric Palliative Care Services and at the Queensland Children's Hospital. He is also Project Lead for the QACA, or the Quality of Care Collaborative Australia, for Pediatric Palliative Care Education. He is a clinician researcher and an active member of PAPCANZ, and I'm not even going to go there, Anthony, but I thought I don't want to take away your conversation. So take it away, Anthony.
Yeah, thank you very much, Mark. And I don't have any slides today. And I am wearing the PAPCANZ hat on behalf of Sarah Fleming, who's our chair, who I think is currently engaging in self-care at the moment on holidays, probably on a biking trip. And I would like to pay my respects to the traditional owners of our land, the elders past, present and emerging. And I do get a sense that we're probably all singing out of the same songbook and probably on the same page. And for us in paediatrics, the child and the family at the centre, but then perhaps different professions represented in different fonts. So the Pediatric Palliative Care Australia New Zealand represents, I guess, the care of neonates, children and adolescents. And it's an interprofessional group, so it includes medical, nursing and allied health. We acknowledge the importance of the discipline-specific groups as well, such as ANSPAN and Palliative Care Nurses Australia, and many of us are also members of those. So how can we support parents and families caring for children with life-limiting conditions? I guess quite a heavy context. Maddie Stepanak had a neuromuscular condition and lived from 1990 to 2004 in the United States and is often described as a poet. He said pediatric palliative care no longer means helping children die well, it means helping children and their families to live well. And then when the time is certain, to help them die gently. How can we help children and their families to live well? And then when the time comes, to die peacefully and with dignity. I guess that reflects one of the themes of the palliative care this year, which was palliative care is more than you think and extends beyond end-of-life care, although that's obviously what we're focused on doing a really good job of. In terms of achievements for PAPCANZ, I guess it's really just the organisation has been established and is now sort of becoming is functioning quite well and having good governance structures. We had an AGM in November of last year, and we're very thankful for Palliative Care Australia's support of PAPCANZ as it's an affiliate member. And there were 2 Queenslanders who were very involved in the formation of this, Lee Donovan, a social worker, and Leanne Pedersen, who's a nurse practitioner. The group actually goes back to about 2003. where with Department of Health, Commonwealth support, a group called the National Pediatric Palliative Care Reference Group formed. And my colleague Helen Irving, also from Brisbane, was an integral member of that. So it's great to see this sort of growth and formation of our group. A second major sort of achievement, I think, for this year has been education. And so PAPCANS has formed an education special interest group, which has become quite active and is also partnering well with the QACA project, which is the federally funded education project. I'll talk shortly more about that. And then Camila did mention the Pediatric project, which is funded again by the Department of Health Commonwealth, was an election promise from the previous election. And I'll give some examples of how that project is working well in partnership with Palliative Care Australia. We have a national action plan that we're developing. There's been significant consultation, particularly with both health professionals and consumers. And I know that there's been 5 or 6 Queensland consumers involved in the consultation process. Nelson Mandela said that education was the most powerful weapon which we could use to change the world. And so certainly education is a key thing of what we're doing to, I guess, increase the capacity of the workforce to provide palliative care support to children and families. A big achievement for this year was the rapid literature review published by the Pediatric Palliative Care National Action Project. And this identified a number of key ways that health professionals can enhance their confidence and skills. These included a number of diverse approaches to identifying and accommodating to learners' needs, simulation-based learning, experiential learning, such as clinical placements, such as what Pepper provides, interprofessional learning, diverse approaches to incorporating family perspectives. And so families acting as co-facilitators of education sessions, e-learning, reflective learning, amongst many others. And I'd just like to acknowledge the Oceanic conference this year, which Camila mentioned, and that had a very strong pediatric presence in terms of content and presentation, but again, really reflecting across the lifespan and other important areas such as aged care. The review that I just mentioned, which was done out of Queensland University of Technology, I didn't have anything directly involved, but it does show I guess the contribution of various Queensland academics and health professionals to this space. It also identified the need to develop the skills of patients and families, or perhaps to empower patients and families, and that such provision of information could foster resilience. And there remains considerable scope to understand optimal initiatives to enhance the skills of patients, their parents or guardians, and their well siblings. And so some of the innovative things that are occurring, the team in the Royal Children's Hospital of Melbourne launched some podcasts only yesterday to I guess try and sort of provide some information resources to patients and families. And so this podcast was called Life, Love and Loss, a podcast for families caring for children who are dying. And the podcast share real and deep experiences of parents who also become, I guess, support for other parents, but also educators for us as health professionals. So that's a little bit on the educational aspect out of the literature review which was done, and this does show, I guess, our desire in what we do to have that based on experience, evidence, and also best practice. Just briefly running through a few other key highlights from the literature review. There were initially 2,744 articles identified in the literature, and they were able to hone that down to 369 articles. And the key themes that were identified was improving the quality of pediatric palliative care, and particularly using our child and family-centered approach, and fostering partnerships across professions and care settings. Another key thing was improving access to pediatric palliative care, particularly for patients in the home, and the access to specialist pediatric palliative care when required. Advanced care planning, improving the skills of the clinical workforce, as well as empowering families. improving research and data collection, improving collaboration across jurisdictions, which I guess what days like today are all about. Improving dissemination of information, and that was particularly around sort of trying to identify who the care circle was for a particular child and making that clear for the family, but also for all those involved in care. I know Anne showed quite a detailed slide of all the different people that could be involved, both health professional, but also non-health professional. And for us in paediatrics, you know, the schools are often very important, as well as cultural and spiritual advisors. And then the final thing was sort of improving community knowledge of paediatric palliative care. So I guess we're trying to, promote, society's understanding of death and dying, and that potentially that could be taken into schools around providing just knowledge around dying and palliative care to high school age children, and how can existing community-based initiatives for improving knowledge of paediatric palliative care be expanded to ensure coverage of the general Australian community. Just our focus for the next year, ongoing advocacy. And so PAPCANS has been asked to give feedback on the palliative care reform program in Queensland, partnership with Palliative Care Australia, with consumers, with the various hospitals and hospices, with New Zealand, and with the Quokka project and other national palliative care projects. And obviously the paediatric project will continue to roll out with the development of the national paediatric palliative care strategy to complement the adult strategy, better understanding of our workforce needs, and also we're hoping to do a new edition of what we call our Green Book, a practical guide to palliative care in paediatrics, which was last done in 2014. So as a national sort of collaboration, we want to update our sort of resource for health professionals. So thank you for the opportunity to present today.
Thanks so much, Anthony, and really looking forward to some of the questions that may pop up for you. And if this, we try and make sure that we can connect you to the links reasonably quickly. But if we happen to overlook anything, please just make a comment and we'll follow up. I'd like to now move on to another dear colleague who has been around for a very long time, Dr. John Rosenberg, who is the President of Public Health Palliative Care International. And John is a registered nurse by background, with a clinical background, and particularly in community-based palliative care. He's also the senior lecturer in the School of Nursing, Midwifery and Paramedicine at the University of the Sunshine Coast. John completed his PhD in 2007. I remember that time well, John. And that was the first ever doctoral study in the emerging field of public health and palliative care. And he's contributed to the research, to teaching, practice, and engagement through various roles since. John is the current president of Public Health Palliative Care International, works closely with Palliative Care Queensland in our public health palliative care activities, including Queensland Compassionate Communities and last aid training. So welcome, John, and thank you for your presentation.
Thanks, Marg and Shyla, and thanks for the invitation to speak today. I'll try to keep to time. Marg and I are tarred with the same brush, I think. I also want to add to the acknowledgement of others of First Nations peoples on whose lands we're meeting today. Just it's interesting for me as a representative of an international organisation that following our Blue Mountains conference 2 years ago, where there was a very strong acknowledgement of Indigenous culture and also the Uluru Statement, that in our meetings, we now have acknowledgements of First Nations peoples as a routine part of our gatherings from all over the world. So we have North America, post-colonial countries like Canada and the United States and Africa and so forth. There are it's a real thing that they've taken on. They saw that happening in our part of the world. So that's been an interesting legacy for the acknowledgements that we do. So as I mentioned, I do have some slides there, so if they could be brought up, that would be great. So I am representing an international organisation, and that's perhaps a little bit different to the presentations up until now. So Public Health Palliative Care International is known to some of you. On the slides that should be appearing at some point very soon. I sent the slides earlier, but I can share my screen. Yes, I'm just getting messages on the side. So we're an international organisation, and what we are is focused, I guess, on the broader social contexts of the experiences of death, dying, loss and grief. And you may be able to tell that I'm multitasking here, trying to get my slides here. Here we go. This looks promising. So can you see that? Can you see that now? Can I just get somebody telling me? Is that still good? Yes.
You can see
Claudia.
slides, John.
Thank you, Anthony. That's great. Okay, so I'm not going to go over in detail who we are, but just to quickly recap that we're underpinned by the principles of and concepts, methods of health promotion into palliative care, because we take the position that healthy dying is a normal part of the human journey, and so we are looking at that the experience of dying has a response that's required from specialist clinicians and generalist clinicians, that's come up earlier, from communities and social networks, and then from civic society as well. So that whilst a lot of the focus in our professional associations is on those professional activities, it is, of course, as we all know, they are part of a bigger picture. And Anthony, I'll just refer to you just mentioning a moment ago that schools are a very important part of paediatric palliative care. And in public health palliative care, we also talk very much about schools, workplaces, places of worship, social groups, that these are part of the civic life in which death and dying, grief and loss take place. So that's very much the focus that we have. We have some aims around the support of members in their education and practice. I'll talk about that a bit more in a moment with a major activity we've just concluded. We have biennial conferences, and we're also challenged by what COVID has done and is doing to us all. And we've got some particular focuses coming up on research and evaluation of health promoting palliative care. This is all based on the premise of partnership between the professional and clinical world and communities. And so we see that there is not necessarily equal, but there is a reciprocal relationship between those two broad groups in order to provide best possible outcomes to promote death literacy and to enable people to live, die and grieve well. So what have we been up to? Well, in response to COVID, we put together a collation of resources from different compassionate communities around the world who have a number of different tools, resources, programs that they are running that assist in retaining connection during a very disconnected time. And so our website, which I'll give in a moment, also has that, that information on it. We've just had two inaugural events that have been on our mind for a while, but it's the opportunity that COVID provided us, because we couldn't hold our scheduled conference in 2021. So we had our inaugural Compassionate Communities Day on the 1st of November, and it was a Chase the Sun across the world event. So it was a rolling online event. We started here in Australasia and we moved our way west as the sun rose in various parts of the world. The focus was very much on the practice wisdom that emerges locally when organisations and communities are creating connections and supporting members of the community to live, die and grieve in their homes and in their communities. The really amazing thing about that was that the contributors were all very much on the ground people in practice or in the practice of compassionate communities, and that was live on Facebook, and you can go to our website on Facebook. You can go to our page on web or Facebook, and you'll find many of the presentations there. It was followed the next day by our inaugural Compassionate Communities Symposium, and Local Action Global Movement is the theme for it. And it was the thought leaders in the area, the innovators, and again, a truly global perspective. And we had some terrific representation from all over the world. Just looking in the chat to see if I'm being told to slow down. No, or speed up. So the World Compassionate Communities Day will be an ongoing concern. 1st of November, an auspicious date because of course it coincides with the Mexican Day of the Dead, All Saints Day in the Christian tradition, and a number of other events. What was, I guess, really pleasing about this event was that we had the input of the World Health Organization, who are acknowledging the importance of these approaches to palliative and end-of-life care and grieving. Now that's looking back. So looking forward, I guess there are some things that are happening for us as a global organization that have an impact for what we can be doing in Queensland. It's priority 3 of Palliative Care Queensland's priorities that we're picking up on, which is work with the community through the philosophy of public health palliative care to increase awareness, engagement and partnerships, which are the kind of sentiments, I guess, that I've been speaking to so far. So in terms of our association, what's coming up, we're looking at consolidating a kind of a global view. The World Health Organization was very supportive of the idea that all over the world there are different things happening that are around this, this connection between services and communities beyond simply the provision of services, so that partnerships and that connection takes place. We're looking also at policy integration of public health palliative care, and some of the work that we're doing with Palliative Care Queensland has that focus. And we have our delayed biennial conference coming up next year, more information to come. Nationally, and certainly Palliative Care Queensland has been involved in this, we're looking at mobilising the Australia and New Zealand network around public health palliative care. And what form that can take and so forth is still a work in progress, but it is an opportunity for people with a specific interest in public health palliative care approaches to meet with like-minded Australian and New Zealand colleagues. I do want to acknowledge that we have on our council, we have another Queenslander, Daniel Lowry from Cairns, and Dan's a powerhouse on our council and has a really strong contribution that he's making. And as a Queenslander, yay, it's great to have him on board. In terms of locally, I guess what we're aiming to do as a global association is to support the engagement with public health palliative care or health promoting palliative care or compassionate communities at a Queensland level. And sometimes that's the implementation of that work, and sometimes it is the support of others who are doing that work. So we see ourselves as a conduit of information and you know, with an opportunity to help inform others who are interested in it about what's available globally. So Canada, Belgium, the UK, Ireland, Australia, Taiwan. These are some of the places that are really concrete in their actions around public health palliative care initiatives. And there's a lot of information out there that can be built on by local efforts. I'm of course missing, you know, some people who should be mentioned, but just within the constraints of time, there's some of the ones I can mention. So I have an invitation. Apart from, once you've joined Palliative Care Queensland, you might consider joining Public Health Palliative Care International, and then you can come to Bruges in Belgium. Why wouldn't you? Look at that picture. So providing the state of the world allows us to, we are having a face-to-face conference next year in Bruges in Belgium. Its theme is democratising caring, dying and grieving, participation, action, understanding and evaluation. Is being led by the very large end-of-life care group based at the Free University and Ghent University. Professor Luke Delians is known to many of you, and he's leading that. So you are invited to come to that conference, and abstracts are open now, so you can consider submitting an abstract, which normally means that your boss will let you have some time off to attend if you're presenting, in my experience. So there's our website. Please have a look at that website. If you would like more information, you can contact us through our secretariat, and they may even put you in touch with me. So thank you very much for the opportunity to speak. Am I allowed to say two more things? Very quickly, we have a journal, the Palliative Care and Social Practice Journal. So yeah, you can contribute to that. And next year will be the release of the Oxford textbook of public health palliative care. So that's a substantial piece of work with many contributors from Australia and across the world. That'll be launched mid-year, will become a major resource for this work. And that's it. And that really is it. I'll stop now.
Thank you so much, John. And also, thank you for passing the test that we throw out randomly to guests to see what sort of IT skills you have. So for demonstrating your expertise in sharing your slides, thank you.
No worries. I do it for a living, so hopefully
yes.
I got it right. Yeah.
Yeah, it was a test. So thank you. So just conscious of time, and don't feel that we're hopefully we're not trying to rush through, but we do have so many excellent speakers. And I'm just going to introduce now Shyla, who is sitting right beside me. And Shyla's actually speaking on behalf of Chris Hall, who was going to address you. Chris is the Chief Executive Officer for the Australian Centre for Grief and Bereavement, and unfortunately he's unwell today. So Shyla has a brief update from Chris, and then we will also provide you with a link to the video of this session as well that was provided to give you an idea of the shared priorities. I just had to have a pause then. So sometimes it's good to do that. So I'll hand over to Shyla, thank you, and look forward to hearing what Chris has to say through your mouth.
Oh, the pressure's on now.
I know.
So thank you, everyone. And I think it's just really important to have grief and bereavement on the agenda. And it's really exciting that even though Chris was unwell, he's managed to share us the top 3 priorities from Australian Centre for Grief and Bereavement. So they do have a wonderful video, and we'll share this in a link to you all. And so it's coming up in the chat, and we really encourage you guys to all watch it. We're not going to share it now because it's just due to time. So these are the top 3 priorities that Chris has shared with us. So the first one is about an increased need to meet the needs of those bereaved as a result of voluntary assisted dying. It talks about many experience self-stigmatization and feel that mainstream services are not meeting their particular and specific needs. We're establishing, or Australian Centre for Grief and Bereavement are establishing bereavement support groups within Victoria for this cohort of bereaved people. So something we could consider up here and learn from other states for Queensland. The second one looks at how do we provide support to those with the highest level of bereavement distress? Overseas or international data indicates that those who are most distressed and require the most support are not seeking the support they need, either because of their belief that it's too painful to talk about it or it won't make any difference. How do we promote bereavement support needs, reconsideration, and how do we include the voices of bereaved people who have benefited from seeking support? And is this part of the answer? And how do we learn from other jurisdictions as well? Helping people to self-manage their bereavement experience to the greatest extent is also important. And they've developed the app, My Grief app, which will also pop up in the chat and is a really good app to share. And they've said that they've had positive feedback in this space. The third priority is to undertake bereavement risk assessments and link people to the most appropriate kinds of support. It's still needed in this sector, and it's particularly needed up in Queensland. I don't know about everyone else, but a lot of the consultation that I'm hearing, where bereavement is a key area that keeps getting raised. Chris says that one size does not fit all, and the allocation of various types of support to various clients is both most effective in terms of outcome and financial responsibility as well. Palliative Care Queensland completed a publication last year, or actually this year, the priorities for palliative care in Queensland 2021, bereavement care. So this is a publication that looked at recommendations across Queensland based on some consultation that we did. So we really encourage you to look at that document and also to look at the app as well, and to get onto the Australian Centre for Grief and Bereavement website so that you can keep up to date with grief and bereavement. Thank you all. Back to you, Mark.
Thank you so much, Chris, aka Shyla. We've had an amazing morning, I think you probably all agree, and we've had in the background a lot of people engaging in the discussion and asking of questions. So we have a short period of time now to look at the questions that are being raised and invite the panel to answer some of those questions. So we might start, Shyla, if you'd like to.
Sure.
Look at your X-ray vision over there.
So the first one is for Leroy. So has the passing of euthanasia legislation impacted on people seeking palliative care? If so, do we have any stats? Thank you.
I was actually going to try and type an answer. Can you hear me now?
Yes.
But I pressed the wrong button, so I failed that IT.
Leroy, it's okay.
Look, yes is the short answer. It has affected people accessing palliative care. We've already talked about a postcode lottery, and therefore people don't necessarily have a choice in terms of what they're choosing between. They also don't understand palliative care, and it's great to hear from Camila that more people know what palliative care is, but when we drill down into that knowledge, sometimes it's not as clear as we think it might be. So yeah, I think that the discussions are very important in terms of who's discussing what palliative care is, and do people really understand what we are trying to do. And in terms of the figures, most of the figures are not being reported, because what's being reported is the process part, the paper filling, that really doesn't talk about the conversations and the really important interactions that happen before the process of voluntary assisted dying starts. So that's where we need to make a clear line as to what we do and how we deal with statements that are wish for hastened death statements. So that's my view.
Thank you so much, Leroy, and thank you for the question there.
We're not muted. Oh, we're talking.
We're
Oh,
live.
see, look, I'm just trying to make you feel better, Leroy.
I don't know if we passed the IT test.
No, we didn't, but that's right. We're just trying to make it all balanced out, everybody. So thank you, Charlotte.
Lovely. So the next question from Kristen says it's about an allied health. So I might throw this one to Alison. You know, obviously you're representing a multi-field there as the social workers, but you can probably give a bit of feedback in this space. So from a national perception in the development of palliative care, are there any allied health representation to advocate for this area? And Kristen has mentioned that her area of expertise is around OTs. So how do people get involved? How do they start advocating in this space? Because it's a great lesson of what PCSWA, which I hadn't known that was the abbreviation before, so very excited about that. How does this start up? How do we start this for different allied health groups?
Oh, look at that. That's a really good question. And I think perhaps Nicole has tried to just share how ways of we all working in palliative care can influence some of the, you know, the reform packages that are happening in Queensland at the moment. So that's just in terms of an immediate thing for would you say, Kristen, as we say? Look, I mean, I wasn't around in the formation of PCSWA, but have joined subsequently. And I think it as I said in the presentation, it grew out of a collective coming together. So there's a there's an Australian Association of Social Workers, and there was some work done around the standards. And I think, you know, when social work works across many different fields and areas, it was hard to kind of, I suppose, get that message, that work kind of clearly differentiated. So it kind of formed out of, so the work was done around the standards, and then there was this, I don't know, a collective of very dynamic people, not me, but very dynamic people who came together to kind of create a national association. And I think it's a time, isn't it? It's there's energy and time, and people are curious about palliative care. There's this there's a flurry of stuff happening at local, state, national levels, and certainly in the PED space as well. And we've heard that this morning. So I'm not sure I'm really answering the question, and I might stop. But yeah, I think it's perhaps a bit of good luck and good management.
Yeah, and I can see lots of people putting little notes in the chat about little linkages in that space.
Fantastic.
I know Care Search has been very involved in the allied health with their hub and everything there. So connect up with these different groups, and you'll find the right people and connecting, and then it's just moving forward, developing all the back end work that you have to do around becoming an association and everything in that space. So it's just very exciting, I think, to see over the years the growth of different peak bodies and different groups in this space. And I think, you know, the idea of increasing allied health funds is really great. So exciting time ahead.
Yeah. Really important to have that voice. I mean, I think I don't pretend to be speaking for all allied health by any stretch, but certainly I'm in the bereavement and you know, psychosocial care space. There's a voice as well as there's need for the representation of our physical therapists, you know, those allied health working in physical therapy arenas. It's terrible. I'm throwing my hands around a lot when I'm talking, which is really weird when you're talking to a screen. I'll stop.
You know, because look, we have pens and everything. So, you know, I tend to use that, but I'll do that for you just so you feel good. It's all about making our guests feel welcome, Alison. So thank you. So conscious of time. And I really wanted to say thank you to all of our guests and our speakers. I do hope that you've got something out of this morning and a lot to reflect on. And essentially, we've done the connection with our national update. So we're really getting that sort of broad umbrella lens. See, Alison, I'm doing it already now. You've made it's like the sneeze. So there, I hope it makes you feel good. But we'd like to say a big thank you to PalCare Software for sponsoring and supporting this event for us. This event hasn't ended, so we've just started. So we're kind of moving into that pit stop, you know, being able to go and have a break. And we really would like to invite you, if you haven't already considered it, to come back at 1 o'clock for the statewide update because we have some fantastic speakers there. But what I wanted to do was just to make a bit of a shout out for an end of year event that's coming, that's really quite special. We'll see the slide coming up shortly. I'm not going to rush our, oh yes, there we are, look. The fundraising gala dinner will be happening in person at the Hilton on the 11th of December. And there are still tables available. We've got some people that are competing to see if they can get the most tables out there. So don't be one of those left on the shelf, okay? So pretty sure it'll be a fabulous night, mostly because I do get to come along and have a conversation with you, with my fellow sister, yes, Sister John Hubracht, who was the previous president. So we'll be the sister act. It'll be quite, you know, moderate in terms of entertainment, but we will have a great night. So please consider this as an end of year gathering, but also to recognise and to raise funds for Ambulance Wish, which is a fantastic initiative of Palliative Care Queensland and moving forward. We just wanted to mention that it will be a certificate of attendance if you send an email to help at hello@PCQ, and we'll also be sending out evaluations. And I really would encourage you with the evaluations, everybody. It helps us to move forward to ensure that this is a really good session for future year and years, and you know, to recognise any of your thoughts and comments. PDF slides will be available of the presentations for those of you who are interested in the slides. If for the speakers that didn't have presentations, that's absolutely fine. I think the dialogue and this will be recorded, so people will be able to go back and watch for those who have registered. So thank you for your time, for your energy, your passion and commitment. And I think
Self-care now.
Self-care now.
Until 1 o'clock.
Until 1. So don't be a stranger. Come back and see us. And thank you all again for this morning. Bye.
Thank you,
Thank
everyone.
you.
Thanks all the great speakers.
Bye-bye.
the right angle you want. It still might be right. It might be too glary.
Well, hello. Welcome back, everybody. For those of you who are, have returned from your self-care break from this morning's session, thank you so much for joining us this afternoon. And for our new registrations, we're really looking forward to another excellent session this afternoon. My name is Marg Adams. I'm the President of Palliative Care Queensland, and I'm supported by Shyla Mills, who is the fabulous CEO of Palliative Care Queensland. We're really wanting to welcome you all again, as I said, and thank you for participating in the national update this morning. For those of you who are joining us for the first time, this is our 2021 Palliative Care Queensland Annual Summit, and this is probably our third year, and it really is evolving over time. I really value the contributions that people are making in terms of participation and feedback. So this afternoon session, we're going to have a look at what's happening across the sector in Queensland, in palliative care sector in Queensland. This session, as with this morning, will be recorded. So we're just wanting to mention that we want to be mindful of the diversity in the room and passions in terms of our comments that are going through the chat and our Q&A. If you've got a burning desire to talk further about an issue that's probably something that's not reflected in the session today, or it's raised some concerns or ideas, please make contact with us at hello
At Palliative
at
Care
Palliative Care
Queensland.
Queensland. Yeah. So we're going to start. Okay. So what we'll do is just start with acknowledging the traditional. We've got a person. Do you know what? We have helpers behind the scenes. So this is showing you it's real time. We're not recorded. Okay, make you feel relaxed. We'd like to begin by acknowledging the traditional custodians of the lands on which we gather today, and wherever you are today, and pay our respects to elders past, present, and emerging. And we extend that respect to Aboriginal and Torres Strait Islander peoples here today. And thank you. So we will probably cross across now to to me. I'm going to tell you what we're happening. So I just wanted to show you that, you know, we're sort of polished up after our rest. So I just need to get back into the rhythm. So as a peak body, Palliative Care Queensland is a leading charity for palliative care in Queensland, and our organisational priorities are that all Queenslanders are able to live every day until their last, and are able to have a dignified death, regardless of their illness, age, culture, or location. We also hope that people in Queensland have access to a supportive social network at the end phase of life and have a choice of quality palliative care. Today, we're supported by our members, so thank you to our members, to the partners in the Queensland Government for the support of this event. The annual summit has also been sponsored by Palcare Software company. Palcare is a secure, encrypted, web-based patient information management system. So it'd be well worth having a look into that. We've decided to make today a free event. And I think that when you look at conferences, we have the cream of the crop, and as I took note, we have the Brains Trust, I think, across the country with the national peaks, and also for our colleagues working across and representing the state of Queensland. So if you are up for making a donation, we'd say thank you for that, and would really appreciate it, and it's tax deductible too. The other point we'd like to do here is to acknowledge our Palliative Care Queensland board members, our Strategic Advisory Committee members, Palliative Care Queensland members, and our staff and volunteers who, through their efforts, continue to tirelessly champion the palliative care sector in Queensland. So I'll just pass across to Shyla now, and she will give you a bit more of an update on the purpose of this event. Shyla.
Lovely. Well, thank you all, everyone. So yeah, this event is the big event for Palliative Care Queensland's advocacy and policy area of the team. So we aim to be the collective voice as the peak body for palliative care, and we run 3 events as part of our summit, or 3 activities. So the summit has this event today, which we call a bit of the state of the state. So it's got a national and a state update, and we ask everyone to identify their priorities for palliative care in Queensland for the next 12 months in this space, as well as a bit of an update of where they're at the moment, and some lessons learnt so that we can share them widely with the sector. Then we do a series of roundtables, which we'll be holding in the next couple of weeks as well. And these are on particular focus topics in the space. And during that time, we look at identifying key improvement areas for each of these focus topic areas. And then lastly, we do an annual sector pulse check, as we like to say. It's really a sector poll. And we ask everyone around those priorities as well. Then our wonderful team themes this all up. And then during National Palliative Care Week, we launch the document, which is the priorities for palliative care in Queensland. So the next one will be 2022 to 2023. And we share that at that time during National Palliative Care Week. And the aim really is to get, recognising that the sector only has limited resources, but if we all work together in the same direction, we'll be able to have a collective effort to really make those priorities improve the sector and make better outcomes for the sector and for the consumers and the patients, their families and the community around them as well. So that's the big update of what this is all about.
Excellent. And we've got 2 hours together, and it will be 2 hours of rich sharing of information and views and wishes, hopes and dreams. And reflections. So until 3 o'clock, we'll be hearing from representatives from a number of peak bodies, national peaks and key organisations relevant to palliative care. But this in particular will be our state focus for the next couple of hours. Some of our presenters will be doing a live video with PowerPoint presentation, and some will do a general conversation, which is fabulous. And remembering this is recorded. The presentations slides will be available in PDF, and we'll coordinate the circulation of those over the coming days after this finishes. So we've got the speakers answering 2 questions on behalf of I guess this session, and we want to know their achievements and lessons that have been learned in the last year relevant to Queensland palliative care in the sector, and also share the 3 priorities for the Queensland palliative care sector for 2022-23. And then after each speaker has presented, I'll introduce the next speaker. So it's a well-oiled machine, I can tell you. We're getting better. And then we'll answer questions at the end. So we've got time protected. So if you've got a burning question, if you could pop that in the Q&A box as you're typing away there, and we will get around to referring that to the members of the panel as we get to the end. So without further ado, I would like to begin our state update. And if we can start, I think, by acknowledging the value of our consumers, carers and community, particularly if they are the purpose for our being. And it's essential that we hear their voices, and we have their opportunities for them to share what is important to them. So I'm delighted to introduce Anne Curtis, who is the engagement consultant for specific projects for Health Consumers Queensland. And Anne's going to have a chat to you about some of the projects that she's been working on and engaging with consumers across our state. So welcome, Anne.
Thanks, Mark and Shyla. While I'm waiting for my PowerPoint to come on, oh, here we go. We could have that as up as presentation mode. That would be great. Thank you. I would like to start by acknowledging the traditional owners of the lands in which we all meet today. And I'm on Kpmg land, and also to pay my respects to elders past, present and emerging. So for the last 3 years, I've had an incredible opportunity through Queensland Health and Palliative Care Queensland to do a lot of consultation with consumers across the state, talking about ageing, end-of-life care and dying in 2019, and moving through to a whole lot of different palliative care work. but also doing high benefit care at the end of life this year, and written now, just finished this week, 6 weeks or 2 weeks of consumers out there consulting with their communities around the new palliative care and end-of-life care strategy for Queensland. So if we can show up my slides, that would be great. There's just a white box there. Excellent. So can we go to the first slide, please? In presentation mode. Back to the first slide, the opening one, if you wouldn't mind for a moment. Thank you. I just wanted to share the photo that is on the first page of my presentation, because I just feel that this shows how beautiful the opportunities are that we have when we go out and consult with community. And this is a compilation photo of a yarning circle held during a weaving circle in Hervey Bay. And it is, you know, it's how beautiful to sit there in community and have a discussion about palliative and end-of-life care while you're also weaving at the same time. So thank you. If we can move to the second slide. The work I do is mainly through kitchen table discussions, but there are also yarning circles when our First Nations people lead. This photo here is a session that was held in Tambo for this consultation. And the beauty about this is that it's consumers are the ones who are engaging with their community. So we're not in the room, health staff not in the room, professional consultants not in the room. All of the hosts have the same questions, and usually only 5 or 6 questions, and basically they take it, they choose the venue, the time, the date within a set period of time, but they do the work, and they are the ones who bring it back to us to analyse and write up a report for Queensland Health. So basically, if we can move on to the next slide. Thank you. So this consultation for Queensland Health, and I want to thank Queensland Health for the opportunity to do this work. We ran 16 kitchen table discussions. We were trying to get one in every HHS region so we could hear all voices, and also pediatric palliative care. We had 142 consumers and carers involved in this consultation across 14 towns in the city, and a lot of rural and remote feedback. Just moving on to the next slide. So we heard from very diverse voices, from people from other cultures, First Nations people, people with chronic complex conditions, people who have cared for people in palliative care or in palliative care, recently bereaved people, pediatric palliative care. It's such a diverse disability, such a diverse group of people. But what I wanted to cover this afternoon, excuse me, was to actually talk about what worked well in relation to a patient and their loved one's experience of palliative care, and how could this be expanded so others can also experience the same care. And I've got to say, the amount of feedback we got was absolutely extraordinary to this whole consultation, which shows you the interest in palliative and end-of-life care in this state. So to say that giving the patient, oh, can I please go back? Giving the patient an understanding of what palliative care is. Sorry, forward, one more, thank you, stay there. Giving the patient understanding what palliative care is. Now that's something that they ask for a lot, support and care, not just death and dying. You know, what's worked well is care team working well, managing pain, and all care is coordinated. Putting the person receiving care first, allowing choice of where services are accessed, whether that's in a hospital or a home, appropriately staffed palliative care facilities, and others that were really specifically brought up were the rural and remote palliative care telehealth service from the Gold Coast, the specialist palliative care and aged care space project, the medical aid subsidy scheme palliative care equipment program is excellent, and there was a trial of caring at home boxes was also excellent, and I understand that was around medication and showing carers how to give medication. So if we can move to the next slide, that would just be brilliant. Thank you. So what also worked well was they, you know, in smaller towns and areas, it was the multi-purpose health services are there for support. Rural citizens, however, they say are very limited with options. So obviously there's a need for more infrastructure and staffing. Hospice care is another area that works incredibly well, and having Hummingbird House to go to. Having contact with similar families locally or overseas, especially around pediatric palliative care, where you have young people with, sort of not normal conditions. So that finding another family they can relate to is incredibly important and works really well. Transition to care at the end of a shift to the oncoming staff. That also came up as, so that families don't have to keep repeating over and over as staff move from one shift to the next. Having continuity of caregivers for those in the final stages, that just the same staff that can be there through that journey for people is important. Having a good hospital bed supplied in the home, that's a benefit. Appropriate staff numbers and appropriately trained palliative care staff. Having carers in the home for as long as possible, and focus on individual needs as opposed to putting everyone in a box. So seeing each person as an individual person, and openness to allowing alternative treatments, rituals and ceremonies within the hospital setting or the hospice setting. So moving on to the next one. Thank you. Also, they were saying that terminology is still very complex, so that needs to be broken down for the patient and the family to understand. And they would want, what works is when you've got no limit to the amount of people that can visit at any time of day or night as someone nears the end of their journey. And it's also, for others, it's important to look at what's the decor, when you're decorating that space for palliative care units and rooms. Again, that access to all sorts of alternative therapies from when diagnosis is made is a benefit, and having a team of caring personal carers to support the patient and the carers. Ambulance Wish Queensland type services that would like an every area of Queensland. And what also would work well is availability and support for palliative care, for palliative patient wishes. So moving on to the next slide, thank you. There were 3 priority actions. We asked what were 3 priority actions for government. And just to start with this, they said increase funding for palliative care, equal access to palliative care in rural and remote regions, education for community and what palliative care is and when it begins and ends. That came up continually. Being respectful of cultural needs and training and education for health staff. If you'd like to move on, thank you. So around those 3 priority actions for government, next slide. When it came to for patients and families, that again, it's like a consistent message that was coming out of all of this. Make palliative care accessible to everyone. More community education to what palliative care means and what is available. When does palliative care start? How do you access the services? When does it end? More palliative care rooms to accommodate the family and make facilities available for 6 patients minimum. Now that came from Texas, where there are 2 beds in the hospital and they're both taken up at the moment. So there's no room for anyone else who is in palliative care. Bereavement care, counselling services, again, continually came up throughout the whole consultation, especially around that bereavement care. Enabling people to stay at home for as long as they need or want to, and a real need for the recognition of the role of the carer and the exhaustion they are dealing with. Also, access to phone and internet and laptops for those who don't have funds. And around paediatric palliative care, case managers and care coordinators transition from hospital coordinated care across all service providers. But the other thing they said is to always respect the wishes of the person receiving care and their families. There is no one size fits all model. So see each person or each case as unique. Thank you. Next slide. So around care team and health staff, they talked about enhanced cultural diversity and respect within the health system. High quality care is affordable and available to everyone again. Priorities also being support during non-office hours, 24-hour access to palliative care specialist. I know of a situation, one of the stories that was shared of someone whose partner was in their last few days of life being cared for at home, and they actually didn't realise that they could call palliative care nurses on the weekend, and yet that service was there and available for them. More palliative care specialists and trained staff in rural and remote areas, compassion for all involved in the process, no judgmental care, connection and referrals to support services and supports, caring staff, to consider cultural backgrounds, tradition, cultural values and language other than English. Social workers came up a lot to be specific to end-of-life care, who could answer the patient and or family specific questions. Practical what to do next step, especially when everything happens suddenly and you're given a diagnosis and you're in palliative care, knowing what those steps are is important. Individualised and tailored response for each individual person again, and medical staff to have had the hard conversations and be transparent. And they would like to see training for staff in actually knowing how to have those hard conversations. But I also like the fact that they said staff feel as though they have complete support with both professional training, development and access to quality wellbeing programs that allow them to offer the best of themselves professionally, but at the same time, they have a high level of personal achievement and a love for their work. And next one, which I think is my last one, so this is around the system and hospitals and health services. Pediatric palliative care room in each rural community health facility. A priority is equity and funding for rural and remote services to parity of access to that in metropolitan areas. Extension of funding for caring at home medication boxes and palliative care needs rounds. Specialist palliative care services for those caring for children and younger adults with terminal illness and conditions. Fund and support a workforce with specialised palliative care skills, competencies, experience and training. Funding for building the facilities to allow patients or families to have dignity at the final stage of life, and particularly in those rural and remote areas. And they also talked about research and quality improvement activities for end-of-life care. A specialist palliative care facility at Royal Brisbane Hospital was a request. And easier access for services, and more focus on isolated communities, Aboriginal communities. This is culturally important for our First Nations people to be on country and with family at this time. And the other one that they said was take palliative care to where the people are, whether that's in caravan parks, wherever that is, that's where care needs to be. So thank you very much for the opportunity to speak today.
Oh, thank you. So I was just getting the nod. Yes, I've got the voice. And thank you so much. And I think just being able to start this afternoon with the voices and views and opinions of our consumers is really so important. And so thank you, Anne. I'd like to now introduce David Harmer to the community of this session now, and David is the Senior Director of Social Policy and Legislation Branch in the Office of the Director General and Systems Strategy Division of Queensland Health. David has worked in the Queensland Government since 2005, contributing to the development of policy and legislation in a range of portfolios. David's worked in Queensland Health since 2015 and currently leads the branch in developing key policies and legislation to guide and protect the health of Queenslanders. The branch manages Queensland's health response to a range of policy issues, including older persons' health, aged and palliative care, the National Disability Insurance Scheme, multicultural health, domestic and family violence, child safety, and the Queensland Government's Advancing Health 2026 initiative. Since 2020, David has contributed to the development of COVID-19 policy responses for older Queenslanders, Queenslanders with disabilities, and culturally and linguistically diverse communities in Queensland. He represents Queensland Health in a number of national forums and is Queensland Health's representative on the AHPPC Aged Care Advisory Group. And unfortunately, our Health Minister was unable to attend today due to being in sittings this week. However, David will be able to share a message from the Minister during his presentation. So David, a warm welcome to you and thank you for coming along this afternoon.
Hi, thank you, Marg. Hi, Shyla. Good afternoon, everyone. That mental note to shorten my bio, that's way too long. But I too would like to begin by acknowledging the traditional owners of the land on which we're meeting, wherever we are in Queensland today. It struck me when seeing Auntie Edna's ambulance wish granted just recently how important palliative care is to people in Queensland, but also how important it is to our First Nations people. And, you know, the fact that Palliative Care Queensland was able to grant her wish to visit her ancestral countries, or at least one of her ancestral countries, in Jiribah or Stradbroke, to walk with her family, really does remind us of our First Nations people's enduring connection to the land and the importance of understanding different perspectives of palliative care. So I really want to congratulate Palliative Care Queensland on fulfilling that wish. It was a remarkable one and a particularly compelling story. So well done. As Marg mentioned, the Minister for Health couldn't be here. She wanted to be, but Parliament's on today, and for some reason, politicians have to go to Parliament. So she does send her apologies and ask that I speak on her behalf, particularly to thank Palliative Care Queensland for its leadership in organising this event. It's a fantastic conversation every year and an important one. But more importantly, to acknowledge and thank you, the medical, nursing and allied health professionals, carers and volunteers who provide palliative care to Queenslanders with such incredible compassion and commitment. You know, there are very few people who can care for someone with a life-limiting illness, who can meet their physical, social, cultural and spiritual needs and provide support to their loved ones. You do it with such passion and grace. It is an absolute privilege to work with you and to have this opportunity to speak to you today. So thank you on behalf of the Minister for the great work that you do, and thank you personally. In the time that I've been allocated to speak today, I'm going to tell you a little bit about the work of Social Policy and Legislation branch as it relates to palliative care, focusing on our work with palliative care stakeholders to finalise the government's plans for new investment in palliative care. Following the parliamentary inquiry into aged care, end-of-life care, palliative care and voluntary assisted dying, which was completed just over a year ago now, the Queensland Government committed to investing $171 million of new funding for palliative care over 5 years as part of the Palliative Care Reform Program. This new investment, which includes recurrent funding, will mean the government spends approximately $250 million annually on palliative care by the financial year 2025-26. The Palliative Care Reform Program will build on existing palliative care investments in clinical, advisory, information, referral and support services. And as you can see from my first slide, which is there on the screen, fantastic service there, Palliative Care Queensland, the Queensland Government will make new investments aimed at building the capacity of our frontline workforce, creating new capabilities to deliver community-based palliative care in rural, remote and regional Queensland. It will also spend on digital services and telehealth support and on education and advocacy about death and dying of palliative care. So I'm just getting feedback. Is that something we can fix? The program will be informed by a new palliative and end-of-life care strategy, which we are co-designing now with palliative care stakeholders and consumers. And finalising the strategy will continue to be our focus as we enter the new year. Once approved, the strategy will guide the government's investment in palliative care for the next few years. That said, work has already started on key elements of the program. Last week, you might have noticed that the Minister announced a commissioning process for the new investment in community-based palliative care, and an invitation to offer, or ITO, was released on the Qtender website last week. The invitation to offer seeks proposals from non-government organisations wanting to deliver community-based palliative care services outside of Southeast Queensland, with the aim of services commencing from 1 October 2022. If you haven't seen the ITO, please visit the Qtender website. Share the link with people who might be interested. If you're not familiar with the website, you can find it simply by Googling Qtender, so capital Q, capital T, E-N-D-E-R. And then once you're at the site, if you search for palliative care, you'll see a list come up. And I think the one at the top that is active is the ITO that you're interested in reading about. An industry briefing will be held next week on the 22nd of November. And you can find details about that on the QTender website when you get there. So I encourage those with an interest to have a look and to share that information as broadly as possible. When announcing the invitation to offer the Minister confirmed recurrent funding for the statewide specialist palliative care rural telehealth service and the Pediatric Palliative Care Outreach Collaborative, both important and very successful initiatives, Nick Steele, the Deputy Director General of our Healthcare Purchasing and System Performance Division, has written to Healthcare Service Chief Executives about the investment outcome, and it will be incorporated into the development of the palliative and end-of-life care strategy. The important thing about this announcement is it actually signals a continuing investment from the government to these initiatives, but perhaps more importantly, it's a further investment on top of the $171 million that will be an enduring commitment in the palliative care space. I just want to focus more now on the reform program. So the palliative care reform program aims to strengthen service delivery across the continuum of care, from primary care to hospital-based services, to deliver better outcomes for palliative care patients. Recognising, of course, that we work in a federated system, we've only got so much control over what happens in the primary care space, but we are committed to working together across healthcare systems to get the best outcome possible. As I've already mentioned, we will expand the delivery of community-based services outside Queensland's southeast corner and support this by investing in improved telehealth services and support for clinicians to build capability across the sector. The reform program includes $102.5 million to attract, recruit and retain additional frontline specialist palliative care staff, which will be informed by a workforce plan. It is expected that the investment in workforce guided by the plan will increase the number of frontline specialist palliative care workers and significantly enhance the capability of our palliative care workforce to provide quality care across the state, improving equity of access for palliative care for all Queenslanders. Advanced care planning is another important focus under the reform program, along with education and awareness initiatives. Investments to increase digital and telehealth services and 24/7 advice for palliative care practitioners is also planned. Queensland Health, in designing the strategy and in working to finalise the arrangements, is building on the engagement and public consultation that occurred through the parliamentary inquiry process as we develop the reform program. We are acutely aware that so many of you made meaningful contributions to the parliamentary committee process, and we're really keen to ensure that that knowledge and information is not lost. We know we can't deliver an effective program if it's not co-designed with consumers and palliative care experts, and we've started our engagement process to ensure the program design is informed by the collective knowledge, expertise and lived experiences of palliative care stakeholders and consumers. So very much the people on this forum this afternoon. As you've heard from Anne already, engagements, sorry, I'm reading the wrong line. Engagement sessions have occurred with all 16 hospital and health services, and this has been followed by facilitated workshops with specialist palliative care clinicians, including nurses, physicians, allied health specialists and social workers. Targeted consultation is currently being undertaken with a broad range of stakeholders and is focusing on seeking feedback on proposed principles, goals and actions for the strategy. As you've just heard from Anne, Queensland Health has partnered with Health Consumers Queensland, and Anne and her team have facilitated those fantastic kitchen table discussions, which have been so informative. They've occurred around Queensland, as you've already heard, and are really offering some perspectives that we haven't heard before in all cases, and weren't necessarily heard during the parliamentary committee process, which is fantastic. I forget whether Anne mentioned this or not, but that process has allowed over 140 participants from a diverse range of communities, including some discrete communities that typically haven't engaged with palliative care discussions before, to have a voice, which is absolutely fantastic. Palliative Care Queensland is also playing an important role in the development of the program and shaping our thinking about how to make the investments. So it has facilitated workshops on Queensland Health's behalf to engage hospices and hospice service providers, to speak with peak bodies and primary health networks on the strategy's proposed principles, goals, and potential actions. We've heard from people like you about local and system level program and policy challenges and opportunities and things you'd like to see happen in the reform space. We've heard about new areas in which we could build capability and capacity, such as the specific needs of meeting the specific needs of people with degenerative conditions. We've also heard about the need for growth, training and support for statewide specialist workforce. We've heard about the importance of programs that bolster partnerships with the primary care sector and increase capacity and capability to deliver palliative care services to Queenslanders in their communities. We've also heard about the need for ongoing state advocacy and how we need to continue to lobby the Commonwealth for new funding and better ways in which funding and investment could be delivered to fill gaps. As a consequence of this engagement and the information and advice we've received from Health Consumers Queensland, Palliative Care Queensland, our clinical experts and stakeholders directly, we now better understand the gaps in palliative care services for culturally and linguistically diverse populations, and we will consider opportunities that can better provide for patients and their families' cultural and spiritual needs. We've heard about health equity challenges for First Nations peoples, and I'm pleased that my colleague Aaron, I think, will be speaking more about that later. But we have heard about workforce factors that inhibit culturally appropriate care. The need for bereavement care, both ahead of and after a loved one's passing, has been raised as a key need across Queensland, and better support for families has been identified as a key priority. Palliative care is a vital service that we need to deliver differently, and our system needs to be reconfigured so that it can flexibly respond to need and demand across the state. Into the future, hub and spoke models that mitigate access challenges for regional, rural and remote locations and other flexible and responsive service delivery models need to be investigated. As we look to deliver on these focus areas and increase the sector's capacity and capability, we will be continuing to deliver and build on existing proven palliative care services and initiatives. A lot of work has occurred, and I particularly want to acknowledge the staff in Queensland Health who've thrown themselves at this while juggling the competing priorities COVID-19 has created for departments across the country. There's a lot of work to do, and we look forward to continuing this journey in 2022 and continuing to work with you particularly. Before I stop talking, I do want to speak briefly about voluntary assisted dying in Queensland. And I acknowledge and respect that voluntary assisted dying is a challenging concept for many people, and that many Queenslanders, possibly including people on the call today, hold deeply personal views about VAD, whether for or against. In Queensland, the Voluntary Assisted Dying Act will commence on the 1st of January 2023, following a 15-month implementation period. It will give eligible Queenslanders the right to seek a voluntary assisted death. I want to assure you that the team in Queensland Health working to develop the palliative care reform program understand that a voluntary assisted death will be one end-of-life choice available to eligible Queenslanders, but it is not their only choice. I also want to assure you that we understand that palliative care and voluntary assisted death are not mutually exclusive concepts. Eligible Queenslanders who seek a voluntary assisted death under the new framework and their loved ones will require holistic palliative care. Most importantly, I wanted to assure you that we understand that palliative care has the potential to afford every Queenslander living with a life-limiting illness the ability to die with dignity. We know the value of compassionate, high quality and accessible palliative care. I want to make it clear too that none of the $170 million allocated for new investment in palliative care will be spent to give effect to the voluntary assisted dying scheme's implementation. That program will be funded entirely separately from the investment Queensland Government is making in palliative care reform. So in that context, the new funding for palliative care reform gives us an exciting opportunity to work together to deliver high quality palliative care across Queensland. It represents an opportunity to look at what's currently working well, what we might do differently, and what we can enhance or create to deliver better access and equity of access to palliative care in Queensland. In conclusion, I wanted to acknowledge everyone participating today for your passion and advocacy, for the work that you do every day to care for Queenslanders. You've achieved an incredible amount, and I'm sure you'll continue to do that. But I know there's more we can do together, and this new investment presents us a remarkable opportunity to improve palliative care service delivery in Queensland, and as a result, help more Queenslanders to live and die with dignity, care and support. I look forward to continuing to engage with you all as we progress on this path to improving palliative care, and thank you again for this opportunity to speak to you today. As usual, I've probably spoken a bit fast and gone ahead of time, but I'll hand back to you, Marg and Sharla. Thank you.
David, thank you so much. And you spoke really beautifully. And I just wanted to highlight and give a collective vote of thanks to you, and the message that you've given really does give us a sense of appreciation of the government's value of the role that our people are playing in providing, quality palliative care in this state. So thank you so much for that contribution. And we are really pleased and proud now to introduce Aaron Hoffman, who is a proud First Nation person from the Amman and Wadja language groups in Central Queensland. Aaron has over 23 years experience working in Aboriginal and Torres Strait Islander affairs in the Commonwealth and Queensland governments, including the Department of the Prime Minister and Cabinet, Queensland Department of Education, and a range of other human service departments and agencies. In February 2020, Aaron was appointed as Senior Director Engagement Branch in the Aboriginal and Torres Strait Islander Health Division under the stewardship of the Chief Aboriginal and Torres Strait Islander Health Officer and Deputy Director General, Ms. Haylene Grogan. He is passionate about achieving health equity for First Nations Queenslanders. And just to top it off too, with all your achievements, Aaron, we would like to highlight the fact that you have a Masters of Governance and Public Policy, specialising in public administration, and a Bachelor of Communications, specialising in public relations. So thrilled to have you, and thank you for your presentation.
Thank you, Barb, there for that warm introduction there as well. And thank you for inviting me to participate in today's annual summit. It's really exciting to be here. So thank you. And as you guys know, my name is Aaron Hoffman. I'm one of two senior directors who work in the Aboriginal and Torres Strait Islander Health Division under the stewardship of our Chief Aboriginal and Torres Strait Islander Health Officer, Haylene Grogan. So to start, I would like to acknowledge the traditional custodians of the lands here in Brisbane, in which I am dialing into this meeting, the Turrbal people and the Yuggera people, and pay my respects to their elders, past, present and emerging. I would also like to acknowledge the traditional custodians of the lands across the state in which other people have also joined us today for the annual summit. Can I also extend that acknowledgement there to my non-Indigenous colleagues who walk with us in the spirit of reconciliation to improve outcomes for Aboriginal and Torres Strait Islander peoples. I've been allocated 10 minutes today, and I'm going to use my time to talk about the work that we're currently doing with the Queensland Aboriginal Islander Health Council, commonly referred to as QAIC, and talk about what we're doing in relation to First Nations palliative care. So my colleague before me, David Harmer, a special shout out for all the work that him and his team have done in relation to the palliative care space there as well. And obviously he's given a pretty comprehensive overview just in relation to the current reforms to improve the delivery of palliative care. So I won't repeat anything that he may have said, but I will stress there that these reforms are incredible. And for First Nations people, being prioritised across all of the reforms, including expanding our specialist palliative care in hospitals, investing in community-based care and investing in our palliative care workforce. So for me, this is great news and a real example of health equity in action. So I'm going to talk to you about the quarantine funding, which makes up roughly around 20% of the community-based palliative care funds for First Nations-led community-based palliative care. So firstly, this investment is to support First Nations-led models of care. which means that palliative care and end-of-life care models will be designed and delivered by the Aboriginal and Torres Strait Islander community control sector. Secondly, I want to acknowledge the incredible advocacy and the leadership of Quake, and in particular their CEO, Cleveland Fagan, in lobbying for these funds as part of the broader health equity reforms being driven across the health system. Cleveland is passionate about improving care for mob at the end of life and strengthening the community-based health sector. Now, this is new investment, and importantly, it is recurrent investment after the first 2 years. For years 1 and 2, we have roughly 2.6 and 2.7 million, with recurrent funds of 2.7 million annually based on the successful delivery of effective services. Now, I will state this up front because I know everyone's probably thinking it. Now, it isn't a lot of funding, and we know this won't meet the current demand, but it will provide us with some funding to trial, to test, and also start growing the investment in First Nation-led demonstration models of palliative care. So moving on to slide 3, the next slide, I'm going to spend some time explaining some of our current challenges, which is slide 3. So I'm not sure if we're keeping up with the slides here, but continue on. For Aboriginal and Torres Strait Islander peoples and service providers here today, we all know this well. And many people here today will know it better than me because you work on the ground and this is your job. But I feel this is important for everyone gathered here today, including our non-Indigenous colleagues, to really understand the challenges and health inequities still experienced by First Nations people each and every day. And in the case of palliative care at the end of our lives. So the first question I'm going to ask is a straightforward question. Why is this a priority? Well, the answer is straightforward. Currently, we have very limited community-based palliative care available for First Nations people. Demand simply outstrips supply, especially when it comes to First Nations-led models of care. There aren't many being delivered in Queensland, and there's probably just a handful at most. We need more First Nations-led community palliative care services for many reasons, but for brevity, I will list 4 key challenges that I'll explain. So number 1, challenge 1. We need more community-based palliative care because Aboriginal and Torres Strait Islander peoples pass away younger than non-Indigenous Queenslanders and from different disease profiles. This is the reality, and it's very sad and confronting. Challenge 2, care needs to be both clinically and culturally safe. Both are essential for patient safety and patient outcomes. Cultural safety is important throughout the care continuum, but especially at the end of life and when a person passes away. One of the reasons Aboriginal and Torres Strait Islander people don't access care is because simply we feel culturally unsafe. Now, unfortunately, I don't have the time to deep dive into cultural safety, which is an important topic in itself. But what I will say is that effective, efficient, and appropriate care needs to be both clinically and culturally safe for Aboriginal and Torres Strait Islander peoples. If it's not culturally safe, it will not be effective. Challenge 3. Many Aboriginal and Torres Strait Islander people are strong in culture, community, family, and spirituality. They want to be cared for and pass away in their place of choice. This means many First Nations people will want to return to home to country to pass away. And currently, many people don't have this choice. Challenge 4. We currently have substantial supply constraints in delivering non-hospital based palliative care in rural and remote areas due to a lack of services. Now, I've mentioned 4 key challenges, but there are many, many more. But what I want each of you to take away from this presentation is a genuine understanding about why we need First Nations-led models of palliative care. This is a priority health need, a service gap, and we need to address these challenges in order to provide equity in healthcare. We simply cannot ignore them. Next slide, please. So slide 4. So we know First Nations people have been identified as a priority group, and we are responding in the following ways. Queensland Health has established 2 procurement processes for the 54.8 million available for community-based palliative care. Now, the first procurement process is a general or universal process for all population groups that all community providers can apply for, including our Aboriginal and Torres Strait Islander community-controlled health services and other First Nations health providers. Now, the second procurement process is targeted for the Aboriginal and Torres Strait Islander community-controlled health services only. The Aboriginal and Torres Strait Islander Health Division, which is my team, is responsible for managing and designing the First Nations targeted funds in partnership with Quake and our commissioning and contracting branch. Following the completion of palliative care, following the completion of the procurement process, the First Nations-led services will commence delivery during the 22-23 financial year. Now, this timeframe isn't rushed, which is great, but what it will allow us to do is partner with Quake and work with other key stakeholders across the health system to make the most of this investment. Next slide, please. So what is really exciting is how we're going to develop and use this new investment. Now, at the moment, we're calling them demonstration models of care rather than pilots. Now, the reason for this is because the investment is recurrent, and all funded projects in the first 2 years will include a learning component to build upon the evidence base about what works. Now, the important thing is that we're working in genuine partnership with Quake to co-design the new demonstration models of care. Now, to achieve this, we're holding a workshop with key stakeholders in Brisbane on the 9th of February in 2022 to reach agreement on the investment plan and the proposed models. Now, what this workshop will do is develop principles and priorities for new First Nations community-based investment. Secondly, we will have a greater understanding of the current need and demand for First Nations-led palliative and end-of-life care across Queensland. It will provide us with an opportunity to discuss models of good practice from leading clinicians and service providers. And finally, it will enable us to listen to the voices of consumers, family members, and carers. A key component of the principles and priorities we will discuss will include the service design elements and the workforce requirements of the new investment. Now, the Queensland Health Delegate will have the final authority for the allocation of the funding, but every aspect of this new investment will be co-designed in partnership with Quake. So that brings an end to my presentation today. I really want to thank you for your time and providing me with an opportunity to present. A few of my team members are here today too, and are very keen to learn and to listen from everyone here today. So please share your views and ideas. And also, please reach out to me if you would like any further information in relation to our new investment. Thank you, Barb. Cheers.
Aaron, thank you so much. Fabulous to hear. And I'm sure we will look forward to having a sit down with you and a conversation moving forward as to how we can support and advocate for our First Nations peoples. Certainly, we've done some great work across the state and particularly up in the Cape around Cohen. So, you know, there's some really beautiful opportunities for us ahead. So we do appreciate your time. We would like to now welcome another colleague who has been around for a long time as well, lovely Alison Lovell. We know Alison is a registered nurse for more than 20 years, who's primarily worked in the acute hospital setting, both in Australia and the United Kingdom. After 10 years specialising as a haematology nurse in Queensland's leading bone marrow transplant unit, Alison moved across to the specialty of palliative care nursing. In 2016, since 2016, Alison has coordinated several statewide projects to improve care and, at the end of life in her role as project manager for the Clinical Excellence Department of Queensland. She was also treasurer for Palliative Care Nursing Australia. In 2020, as the Vice President of PCNA for 4 years. So it's lovely seeing all the connections our full-time workforce have in volunteering outside to improve outcomes. So Alison, thank you for your time and look forward to your presentation.
Thanks, Marg. Thanks, Sharla. Yeah, so just before I start, I would like to respectfully acknowledge the Yagara and Turrbal traditional owners of the land on which this event is taking place, and elders both past and present. Just need to cough. That's typical, isn't it? Once you open your mouth, you've got a frog in your throat. So yeah, thank you very much for the opportunity to represent Clinical Excellence Queensland today, and the palliative care projects and statewide activities that Clinical Excellence Queensland are privileged to support. So next slide, please. Thank you. Before we start, I just thought I would give you a bit of an overview of the division that I'm part of. You've heard from David and Aaron, and you're aware the Department of Health is almost as complex as you know, the hospital and health services and the NGO sector and all the rest of it. There's lots of people and different parts of the system. So obviously we work collaboratively across the Department of Health and with other stakeholders, but our particular focus in CEQ is to partner with health services, clinicians and consumers to drive measurable improvements in patient care. So we do this by supporting and facilitating the dissemination of best practice clinical standards, by working very, very closely with clinicians to understand models of care and those sorts of things. So the key sort of groups you'll be aware of that sit within the CEQ are the Senate and the statewide clinical networks. We also have the offices of the Chief Dental, Nursing and Midwifery and Allied Health professions offices within the CEQ. So yeah, as mentioned, our particular team, so Care at End of Life, which is kind of now encompassing a whole range of different projects and activities we work with within the department and across the stakeholders to improve access to high quality and palliative and end of life care. That was a bit of a mouthful. Okay, so next slide. So obviously there's limited time to cover everything that we're involved in, so I just wanted to keep it quite high level. If you do want further information about any of these projects or activities after the presentation, you'll be able to contact me and members of the team. And I did just want to acknowledge the vast amount of work completed by the different project teams, you know, that goes into delivering all of this. And thank them for the opportunity to represent them here today. So yeah, so this just gives you a bit of an idea of the scope of activities. So one of the key ones there being that we are supporting the palliative care reform program. We have Kelly Reeves, who's joined us, our team recently. So we've actually set up a cross-divisional project team to deliver on that reform program, which is very exciting. The Queensland Palliative Care Clinical Network is hosted here in Clinical Excellence Queensland, and that's been a great you know, way for us to consult as part of the strategy development as well. We have the Care at End of Life Collaborative, which had a governance role for the previous statewide strategy for end of life care, and is a really engaged, broad group that continues to function. We have the Specialist Palliative Care and Aged Care project, which is a bilaterally funded 4-year project to improve access to palliative care and aged care. The Office of Advanced Care Planning, CEQ, again, it's a cross-divisional effort, but CEQ, mainly in partnership with the Purchasing Department, has played a role in supporting and working with the Office of Advanced Care Planning and Metro South to deliver that statewide service. Similarly with Pallifarm, which was established last year to improve access to medicines in aged care during the pandemic, and continues to have an impact. And then the Palliative Care at Home project is a new piece of work that we aim to increase access to home-based palliative care for people under 65 who can't access home care using any other funding or packages. There's a bit of a gap there, so we're looking at addressing that. And I neglected to put on there that we had the High Benefit Care at End of Life project as well. So there's so much I couldn't have them all. And then we also have national representation to make sure that we're aligning with national policy and representing Queensland Health at that level as well. So yeah, next slide, please. So I reached out to the different programs to get their perspectives to provide you with, rather than, you know, sort of speaking on behalf of all of these very vast projects and activities. So in regards to the palliative care network, I think can safely say that having this network has really raised the profile of palliative care and really increased our opportunities for palliative care to contribute to system reform agendas. So the funding we received for the Palliative Care at Home project, that was a direct outcome of having a network and being at the table with the Queensland Clinical Network executives. So there's also been a really high degree of multidisciplinary and statewide engagement, which I think demonstrates that there was a demand for the network and a great deal of support for its role and functions. Additionally, the other statewide clinical networks have been very supportive and interested in partnering, which I think really shows a change in culture since we began engaging the broader, I guess, clinical communities and so forth at the beginning of the statewide strategy for end-of-life care. With the space project, one of the key things that we learnt there was that working with the HHSs and allowing them to have that autonomy, but meet some consistent service principles was a really good model, because I think it just sort of outlines those foundations. And I think I heard Aaron saying that's a similar approach that they're doing with the development of Aboriginal and Torres Strait Islander services. So, you know, really just providing that basis and then allowing some autonomy to have those contextually appropriate models. A barrier that we came across, I guess, was looking at, we only had sufficient funding to provide part-time positions in rural and remote areas, and that may have contributed to recruitment delays. So in future, I guess, looking at making sure that we have a minimum of full-time positions in those areas to attract candidates from better resourced areas, I suppose. In terms of the Office of Advanced Care Planning, we've got a lot to be proud of there. That's a very unique system that's actually very, very well developed compared to other jurisdictions, and I would dare say internationally. So you may be aware that we have the ACP tracker, the statewide Office of Advanced Care Planning itself. There's dedicated champions, you know, across the state and within the office who support education, and we also had specific funding incentives and reporting and resources attached to that system. So it's quite comprehensive, but a key lesson as well is that, you know, there really is still opportunities to improve the uptake of ACP. And then with Pallifarm, we've really discovered that there's a very highly motivated pharmacy workforce that is available to support community palliative care, in particular in rural remote communities. There's always a community pharmacist, a pharmacy rather, where the pharmacist is actually the main healthcare professional for these communities. So a real opportunity to leverage that role and define and better promote that role. And next slide, please. So in terms of key challenges and gaps remaining for the network, I think we found that with all of the engagement and enthusiasm and support that we've had for the network, we've actually got a vast list of different opportunities that, you know, we could work collectively on with the network, but unfortunately, like everyone else, we're limited by time and resources. So I guess we just have to have a long-term view, pick off our priorities, and as we mature as a network, you know, yeah, we'll be able to achieve a lot more. But I think in this first year, particularly within the context of the reform and everything that's happening in palliative care, we need to sort of get our, go through the forming phase and just pick off a few key focus areas to look at. With the space project, that we do still need to finish implementation in a couple of the HHSs. It's been identified that having a complementary component of the project that allows sort of a more reactive or responsive approach for acute palliative care issues could be helpful. And obviously looking to secure recurrent funding, but considering that's a bilaterally funded project, we'd be aiming to get commitment from the Commonwealth Government for that. In terms of the Office of Advanced Care Planning, there's still a need to address gaps in ACP literacy, community and clinician, and we do have some plans in place of how we'll go about that. The office has also identified a need for specific funding for advanced care planning facilitators champions, and a need for a source of truth for the acute resuscitation plan as one of the documents that forms part of advanced care planning and is complementary to advanced care planning. I'm just going a bit quick now because I know that we're already 6 minutes over time. So Pallifarm, there's also a need to raise community awareness, particularly about anticipatory prescribing. Having some specific remuneration for pharmacists to support palliative care would be useful. And then also key challenges, obviously COVID, which is a challenge for everyone. So next slide. So the top 3 priorities are kind of sneaked in here. We've got 5, but I've hidden them. So the first one, and these priorities are informed by the project leads across the projects I've mentioned, as well as through the consultation we did for the network in the development of the work plan. So the one that sort of bubbled to the top there is about palliative care and aged care. And I noted that the PCA presentation, sort of mentioned that as well. So that's good that there's that alignment, particularly because it is an issue with a great deal of federal responsibility. So the second one, develop a statewide approach to measuring palliative care patient-reported outcomes and experiences. There's actually a lot of interest in this, and unfortunately, there are other jurisdictions who have done some work in developing a statewide approach. So that's an opportunity for us through the network and potentially to partner with the PCQ and the broader sector to look at an approach that could be fit for purpose across different settings as well. Number 3, which is, we had 2 equally tied there. So promoting uptake of advanced care planning, as well as driving improvements in grief and bereavement support in Queensland, which I think has come up a number of times today as well. And overall, in terms of collective focus for the sector, of course, we would like you to continue to engage in the reform program. So the final slide on our role and what we can do to help. So really just continuing to work collaboratively across the department and with stakeholders to support the reform program and other initiatives. And I think we, through the network and through the Care at End of Life Collaborative and those groups that we've really established good relationships with, we want to continue facilitating opportunities for people to be involved, build those relationships, share knowledge and partner. I think we can make a good contribution to that. And then understanding, again, through the network and the relationships we have, gaining a greater understanding of the multidisciplinary clinician as well as statewide sector needs, and facilitating opportunities for all stakeholders to engage with the department, which I know is happening, and that's evidenced today by all of the different speakers and so forth. But I think, it's all very positive and moving in the right direction, but we'd like to continue making those linkages and making sure that the sector meets its vision and goals. So thank you very much for the opportunity to present.
Thanks so much, Alison. And we'll have opportunities to share some feedback and through the Q&A, but really I do appreciate also the time it takes to put a presentation together and also collect the thoughts when it's a very short period of time. So thanks, Alison. We're just going to move on now to the distinguished Professor Patsy Yates, AM, who will be provided on academics, research and Centre for Palliative Care Research and Education. Patsy is the Executive Dean of QUT's Faculty of Health and Co-Director of QUT's Centre for Healthcare Transformation. As a leader in practice, education and research in nursing and the health sector. She leads a large competitively funded research program focused on developing workforce capacity in cancer, palliative care and aged care, advancing the management of cancer-related symptoms and treatment side effects, and strengthening the nexus between research, policy and practice in cancer, palliative care and aged care. Patsy is the current president of the International Society of Nurses in Cancer Care and a past president of Palliative Care Australia. So I think many of us who have walked through the path and the journey of palliative care in our specialties have come across Patsy in our path. So welcome to Patsy's presentation. Thank you.
Hello, my name's Patsy Yates and I'm talking to you today about CPCRE. It's our 20th anniversary this year. We started in 2001, so I'm really pleased to give you a bit of an update on the activities that CPCRE has been working on and some thoughts about priorities for the future. I'd like to start by acknowledging the traditional custodians of the lands on which we're meeting today, and for me that's the people of
Sorry, everyone, we're having a little bit of technical difficulties.
Yes.
So we're just quickly seeing if we can resolve it. Otherwise, we will move on and we'll share this video with everyone.
Yes.
2000. Hello, my name's Patsy Yates and I'm talking to you today about CPCRE. It's our 20th anniversary this year. We were started in 2001, and so I'm really pleased to give you a bit of an update on the activities that CPCRE has been working on and some thoughts about priorities for the future. But I'd like to start by acknowledging traditional custodians of the lands on which we're meeting today, and for me that's the people of the Turrbal and Yagara as the First Nations owners, where QUT stands, where I'm talking to you from today. And we pay respects to their elders, laws, customs and creation spirits, and recognise that these lands have always been places of teaching, research and learning. And QUT acknowledges the important role Aboriginal and Torres Strait Islander people play within the QUT community. So CPCRE, many of you I'm sure are aware of who we are. We're the Centre for Palliative Care Research and Education, established in 2001 by Queensland Health to spearhead efforts in palliative care research and education. So we have two primary roles, and that is around research and education, building capacity in the workforce through those activities and undertaking research to improve the quality of care. We are, of course, part of a big landscape of palliative care organisations in Queensland, and what the way we like to think about CPCRE is that we do play as a statewide body that's based at Royal Brisbane Women's Hospital, but with a statewide remit, that we have a coordination and leadership role, particularly around education and research, that's aligned with the broader strategic directions and in partnership with a whole range of other peak bodies. And what's wonderful to hear today is bringing us all together to talk about those opportunities for collaboration. So our priorities over the most recent period has been looking at, we've got 5 really key priorities. One is about enabling excellence in education to support a capable healthcare workforce. And so this is where our focus is really around looking at quality education that increases the capacity of the healthcare workforce to deliver best practice palliative care. Secondly, leading research to support health service innovation and best practice care. And we've got a program of research, which I'll talk briefly about. Fourthly, translating and embedding knowledge into practice. Fifthly, about fostering collaboration and strategic partnerships. And of course, a big focus is really around strengthening around organisational governance and leadership to achieve those quite significant ambitions. So what have we been working on in 2021-22? Well, a whole series of education events, and you'll be, many of you may be aware that we do deliver our own education that typically we seek to fill gaps where other providers are not delivering those. And typically most of that's actually, a lot of that's outside the Brisbane metro area. And we have a calendar where we also share information about other education activities, which we prepare each year and distribute. We have a website which is basically around keeping a lot of the information about palliative care knowledge, evidence, and links to other repositories of information. We've done particular projects on updating subcutaneous infusion device guidelines. We have a clinical research program that's led by Professor Janet Hardy, and she undertakes a whole range of clinical research activities, and some of the big projects she's working on at the moment are around medicinal cannabis, but she's well known for her leadership in a whole range of building the evidence and symptom management. And we have a health services research program that I lead in collaboration with many other people, that we're looking at a whole range of different activities to looking at different models of care to improve palliative care service delivery across all sectors, and in particular in recent times looking at extending that to the aged care sector. So what have we learned in terms of the delivery of our activities in recent times? Well, we know that no matter how much education we do, that there's continued demand. We continue to be oversubscribed even in these times of COVID, especially in the aged care sector. We know that there's a real need for culturally appropriate education, and we have, as part of our PEPA program, the Program of Experience in the Palliative Approach, where we have an specific Aboriginal and Torres Strait Islander lead who supports that program. We know that that does improve participation in education, and we've got many years now of evidence to demonstrate that. We know that high quality research outputs, and we're reporting new evidence that's generated in Queensland, and that is contributing to build the knowledge base and the lessons that we're learning from that are continuing to ensure evidence-based practices for our community. And we know that there's more new research funding opportunities that are becoming increasingly available in this, as we recognise the need to improve the evidence base. The opportunities for different funding sources to support those efforts are increasing, and we're leading and taking advantage of those opportunities to really secure the resources we need to deliver on our research programs. Some of the key gaps, challenges that I feel are remaining. Well, I think that as there's a lot more attention on palliative care, and it's been so exciting to see the range of different activities and investments in terms of building palliative care capacity in Queensland. I think from an education perspective, one of the issues I think is still really rests around that coordination and the quality of our programs. There's a lot out there, but we need to really work together to ensure that we're not duplicating effort, and that what we deliver is really the best possible, I'm using the best possible educational approaches, and that it's focused on really delivering the outcomes that are needed. Because I think that goes to my next point, and I think one of the challenges there is about sustainability. As I said, we've got demand, continued demand, but we do need to really think about what's the best way to deliver workforce development programs, and in particular education, but as well as workforce planning around that. One of the things we've learned from COVID is that there's many different ways to deliver education that can still deliver good outcomes and that can reach communities, and we need to take advantage of that. I think another key gap is really educating that whole of workforce, not just the specialist workforce, but our primary care providers, aged care providers. We need to really focus on how we're actually meeting the education needs in relation to end-of-life care at all levels. And now some of our work that we're doing, funded through the Department of Health and Ageing, the Commonwealth Department of Health, looking at palliative care curriculum and workforce frameworks, I think is providing some leading frameworks in that area, so that we can understand what's the level of education that's needed for different areas of the workforce. I think there's still some gaps about integrating evidence into policy and practice. I think we're building the evidence base, but we need to do a lot better job at making sure that that's translatable, so that our studies are actually take into account implementation when we're designing and undertaking them, so that we can actually get them into practice much more rapidly. Funding for research, while that's improving in some areas, it still is not sufficient to fill the gaps that we know we need to build that evidence base. And I think also a gap I feel is building that research workforce, particularly the clinical research workforce. I have real concerns about how we're actually sort of generating a new early career, mid-career workforce to actually really lead some of the ongoing need to build evidence in palliative care. So what do I think the top 3 priorities in palliative care sector in Queensland to focus our collective effort? I think efforts of coordination and collaboration. We can't afford to be actually undertaking a whole lot of different activities that aren't really focused on a strategic outcome. So I really am pleased to see that this forum today is bringing people together. I think we need to ensure that all our specialist services meet quality standards. And so that's about reducing variation through our palliative care outcomes collaboration. We know that there's continues to be variation in outcomes, and we need to support all services to have the resources and capacity to actually meet the standards that we expect to be providing to our community. And I think developing sustainable models of care, we know that our in a resource-strapped environment, we really do need to look at better ways to deliver value-based healthcare so that we can reduce those inequities in access and have everyone who deserves palliative care accessing. So those, I think, are some of the priorities from our education and research perspective. So how are our team, how can our team engage to support? Well, I think we do already provide that leadership role and coordination of education and education delivery. And I'm pleased that Kim Griffin, who leads our education program, and that John Hubbard has recently retired. I think that we will continue to play a key role in that space in Queensland. I think we've also been known for educational innovation and some of the opportunities we've had in working through some of the projects funded through the Commonwealth Department of Health, through PEPA and through PCCPU, and also now rolling out a workforce education program through LDAC, our end of life directions in aged care, provides us with a really good opportunity to innovate in terms of how we deliver education. I think workforce planning is another key area that we have an opportunity to take to contribute to as we really try and look at what are the needs of the workforce going forward. And I think service evaluation and health services research is another really critical area that CPCRE has really got a good track record and is well placed to continue to deliver that evidence. So our future for CPCRE, we're in the process of our current strategic plan, which I highlighted those 5 key directions earlier on, is actually needing to be reviewed in the new year. We will, with John Hubbard retiring, be looking at recruiting new team members, hopefully, and really establishing a new team alongside that new strategy. We will continue to work and align with other palliative care initiatives, and we'll continue to build education and research partnerships to ensure that we deliver on our strategic and the key role that we play within the Queensland community. So thank you for the opportunity to share CPCRE, and I want to take this opportunity to thank the staff of CPCRE for all the work that they do, and our partners, and also just acknowledge the significant contribution of John Hubbard over many years and his contribution to CPCRE, and hope that he's enjoying his retirement. So thank you very much, everyone.
Thank you so much, Patsy. And yes, it's lovely to call out and recognise the contributions of John Hubbard, who is a past president of Palliative Care Queensland as well. So a lot of things to think about. Thank you, Patsy. And we will move on now to the next speakers that are representing our hospice network, our hospice service network. And we have the lovely Sue Manton and Dr. Sue Colan. So Sue is starting off with the presentation. And I think just recognising that Sue has 25 years experience practicing medicine, mainly through general practice. It's where I first ran into Sue as a clinical nurse in the community when I was working with Blue Care. And over this time, her interest in palliative care has grown, and Sue's now spending probably half of her time in the palliative care setting, working with an aim to promote the care of the whole human, the whole person, and she does that very beautifully. This incorporates supporting families of patients who are in the necessity of, this incorporates supporting families of patients who are in the terminal phase of a life-limiting illness. Sue is currently working and supporting care with Karuna colleagues, Palliative Care Service, and is grateful to be part of a team and receives nourishment and grounding, which I love this connection. Thank you, Sue, from Coco, her spaniel, her family and her garden. And I think that's a lovely way to segue into Sue. And we're going to introduce Sue. You do it separate? Or?
No, both are going to chat.
Oh, so Sue Manton. Oh, look, I was thinking of pause and then, so anyway, here we go. And Sue Manton, who is the CEO of Little Haven Palliative Care Incorporated. This is an NGO that was seeded 41 years ago in the Gympie region. So it's a long history. and from a compassionate community's desire to provide better care for the dying. A pioneer of hospice care in Queensland, Little Haven is nationally recognised for an outstanding model of efficient and effective community-based palliative care. Little Haven is one of 7 foundation members of Queensland Hospice Services Network, who have together developed a proud history of delivering compassionate care to thousands of Queenslanders in our communities. The network provides an opportunity to discuss common goals and difficulties and work together to ensure sustainability of services, and inspiring and mentoring other organisations looking to improve end-of-life care options in their communities, because as it is said, a rising tide lifts all boats. So to the Sues, thank you so much for your time and your contributions, and we're looking forward to hearing from you.
Thank you very much for the opportunity to present. And this is very much a boots on the ground look at palliative care, because it's community palliative care. Karuna is an NGO, a community service. It's sometimes confusingly referred to as a community hospice, but the place of care for our patients is their home. And Karuna offer 24/7 support. So I'm using Karuna as an example because I'm sure that our experience is mirrored in other community services. So I'm talking initially about what I think have been our achievements, the things we've done differently in the last 12 months. There's been so much wonderful and rich presentation already. And as I say, this is very boots on the ground. We are a clinical service, and we have experienced clinical nurses providing that care. So good symptom control for us is core business. But we know that existential distress for patients and families can sometimes get in the way of managing symptoms. So this year, we've enhanced our clinical service by adding strength to the family support team. Our reasoning is that the greater the strength of support to the patient and their family prior to the death of the patient, the better prepared everybody is. And we do feel that probably bereavement is less problematic. So a counsellor or a social worker contacts the patient or family early after the referral has been accepted, with a general and gentle introduction to the services of the family support team. This doesn't negate our bereavement services, but we feel it establishes a connection very early with the whole person. Another C word, our connections, because our referral base is very broad: GPs, private and public hospitals, outpatients and inpatient units across Metro North, and sometimes even from the area outside Metro North. The referrals to a community service are varied, but include when the patient can no longer travel to an outpatient, when there's been a recent diagnosis with a poor prognosis, when a patient requests end-of-life care at home while still inpatient. And we maintain connection with the referrers in a variety of ways. What we found very useful this year is having MDTs with a couple of the hospitals, so that if admission is necessary, it's as timely as we can make it, hoping to avoid having to send people through emergency. We have found connections with GPs are sometimes difficult because of the myriad of demands that they have, more so with vaccination demand and the Q script introduction. Sometimes patients don't have a GP or have been involved in active treatment for so long that they've lost their connection to the GP. That's been a challenge. We continue to try to make connections with GPs. COVID has changed the landscape. Patients not wanting to go to hospital, family unable to visit, clients being brought home from hospital or residential aged care facilities, interstate families being less able to visit, and support and volunteer visiting programs being paused. We've initiated something in the communication space by starting a podcast series, What About Death? Exploring the many and varied experiences and perceptions of death and dying as a way of increasing death literacy. I often feel that our job is one of a coach. When families want to provide end-of-life care at home, they need coaching. They haven't done this before. We expect them to give medication, including subcut medication. They may need permission to set limits on visitors, for example. It is common for us to be thanked by families. They say, thank you for believing in us to provide this care. We couldn't have done it without you. This is the art of good palliative care. So in summary, in the current COVID environment, we have strengthened our clinical service to address existential distress better. We maintain connection with our referrers to facilitate timely admissions if necessary. We're expanding our communication through podcasts, and we coach families as part of the art of palliative care. When I think of the challenges for our organisation, and I think they're probably mirrored in other organisations, our referral numbers continue to grow. We're in Metro North area of Brisbane. Caboolture is in our area. That's 44 kilometres from our base, and it's one of the fastest growing areas in the state. And Bribie Island, also in our area, is 77 kilometres from our base, and it's a retiree's paradise until people get health problems. So travel costs and time constraints cause some difficulties, particularly if after hours visits are necessary. Travel is a significant consideration for community services. Yes, we know telehealth exists, but face-to-face contact is necessary, particularly as changes occur for patients. End-of-life care, including subcutaneous medication, cannot be commenced or sustained remotely. As an NGO, maintaining a financially viable organisation that can continue our current work and respond to new challenges is an important challenge. The NGOs, Karuna, Little Haven, all the hospices provide vital services to enhance palliative care in Queensland. Conversations about palliative care. Anne Curtis from Health Consumers referred to it. So important. Can we have the necessary tender conversations about death that are necessary? This is everybody's business. Thank you. I'll hand over to Sue Manton.
Hello, thank you, Sue. Sorry, my signal dropped out. We're having a bit of a storm up here. So I'd just like to acknowledge the Gubbi people, which is the land on which we sit, and they've been custodians of this land for 18,000 plus years. And I particularly love that circle of life that is so big in Aboriginal spirituality, because our office is actually we're in the old maternity ward of the hospital. So many of our patients coming in here have been born here as well. So there's that circle. And in fact, my social worker sits in the very place that she was born. That's her office. So it's quite interesting. I think just to quickly go through, Sue's covered off on most of the things. Achievements as far as Little Haven goes. In the last year, we've continued to grow our service, and we're very grateful for the support of Queensland Health with additional funding and recognising the value of community-based palliative care services such as ours in the community. We've had 9% growth in admissions. I think COVID has had its impact with a lot of people not wanting their loved ones in hospital or aged care facilities because of the difficulty in visiting. We've also seen an increased need for bereavement support and family support through that process. So we've grown our allied health, and that's a big fist pump for our allied health, for our social workers. We now have 3 social workers working with us. And I think the other thing that can't be understated is the amount of time and energy that has gone into, from our staff point of view, getting border passes for our families to come up and be with their loved ones at end of life. And early on in the piece, we realised the only way that could happen was by being prepared to provide supervision of quarantine visits. And so we've done that a lot during this last 12 to 18 months. We're also undergoing a USC project, which we just had our first meeting yesterday. We're doing a 6-month research project with USC, analysing our model of care and hopefully showing the economic and societal benefits for other services moving forward. We're looking to have a blueprint of our model of care designed. As far as the little hospice services network goes, I think we have a very proud history in the hospice services network, as I said, of providing all of those services in the initial group of the initial founding hospice services network have been in existence for 20+ years, and we've continued to grow our services. We very much engage with our community. It's very much a community development model where, while we have commonalities, we also are quite different in a lot of ways. So like Karuna, ourselves and Chidamani are very much hospice in the home or community-based palliative care, and that the term hospice is probably a little bit misleading because, as Sue has mentioned, we're doing very clinical work as well, and we, for one, value the early access to palliative care as supporting patients through to the end of life. So a lot of our patients are with us for much longer periods of time, and we work alongside them during active oncology treatments and things like that. We have a very good relationship with our oncologists, who quite simply say people that have palliative care do better than people that don't. So I think that's a very important part of what we do. 3 of our nurses or 3 of our staff members recently attended the Gwendolyn supporting palliative care lectures down in Brisbane on the 9th, and I would encourage you to use that resource as well. There's a very good website there. Apart from that, I think challenges, I'll reiterate what Sue said, that GPs are becoming less engaged than they used to be. I mean, we had as the region grows, they're less engaged and they're under-resourced. They're not well read. We used to be able to get them to do scripts and all sorts of things, but there's not a lot of incentive in that at the moment. So I would encourage, as a sector, for us to be making advocacy for that to be improved. Also, we have a 75-kilometre range from our base. And the Northern Corridor is building, we're seeing more people move to Queensland, and they're moving further away from resources, and so that can be very challenging. With the funding growth, and really do welcome, David, particularly that Queensland Health is investing in community-based palliative care, and I think there's no doubt that that's been a huge part of our advocacy through the hospice services network. But I think with that, you'll see a lot more services pop up, and it is important that they actually are providing specialist palliative care and not just saying that they are. So, people can't, they need to be, the skill set needs to be people that can maintain advanced care planning conversations and life planning, and very specialised in that area. There should be KPIs set around that there's 24/7 support built to life care, and enabling people to be cared for in their place of choice. And I think there's great opportunities, and the Hospice Services Network would welcome and we have been doing it. It's been fantastic to see new services growing, like the Hervey Bay Hospice, which is a beautiful new hospice, which Charlotte and I were both lucky to go up and attend the opening of, and to see them really connecting deep into their communities. I think that we have great value, there's great added value in having that community development model for Queensland Health and for the general public, and for minimising presentations into hospital as well. And also the Fitzroy Hospice is another one that's an emerging model of care, and it's brilliant. And we've very much, I appreciate that everyone within the Hospice Services Network has been very open with sharing information and mentoring those people, and I would encourage that to happen. Thanks.
Thank you both, Suze, very much. And also, could you pass on our thanks to your colleagues at the service level? Thank you. Just conscious of time, and we want to make sure that we give you the time that is due, Philip. Dr. Philip, I beg your pardon. I'll give you a promotion, which is very well deserved. Professor Philip Good is talking about private palliative care services in Queensland. And Philip is the director of St Vincent's Hospital Palliative Care Unit in Brisbane, of the service that offers inpatient and home-based service. Philip is a specialist in palliative medicine and is a specialist in palliative medicine and passionate about seeing that his patients have the highest quality of life possible for as long as possible. Philip has a particular interest in research involving palliative care patients, patient care experience, and medicinal cannabis. I've got all my words tripping. You better check me out later, Philip. He's currently appointed as a professor at the University of Queensland. So aren't we lucky for our future upcomings? Thank you, Philip, for your contribution.
Thanks very much for that. I just want to acknowledge the traditional custodians as well and pay respect to the elders past, present and emerging. Thanks for the opportunity to present today. I'll just make it pretty brief. I'm presenting on behalf, I guess, of private palliative care, but I don't pretend to represent everyone. I work at St Vincent's and also at the Mater. Obviously, another large private palliative care service is the Wesley Inpatient Unit in Brisbane. But just to note that around about 25% of all palliative care is provided by the private sector. And I think that's a really important thing to take into account when we're looking at strategies going into the future. In terms of achievements and lessons learned, there's a few things I got from people about just highlights. I think at St Vincent's, I'd just like to mention about a couple of things. One was we partner with two different private health insurers with two programs. One's with Bupa and one's with Medibank. We have just come up to the 5th year with Bupa and the 1st year with Medibank. So the last year we've been doing that. Two different models of care, two different funded models of care. And that's been really helpful for us to look at that. Some highlights from the Medibank program we found in the last 12 months is that it's a very specific program aimed at people towards the end of life. And with the Medibank program, we've been able to achieve an 80% home death rate from that point of view, which we think is really good. It's also helped us look at the difference between a Bupa program, which is a activity-based funded model, which means for every activity you get funded, as opposed to a Medibank program, which we use as a per capita, which gets you a certain amount per episode of care, which I guess in some ways is how Queensland Health funds a lot of us. I think the lessons from that are things like that it's really important to be patient-centered, and the ability to do that really makes a difference. And that's talked about a lot, but the actual funding models and the ability to do that is very hard. The difference between preferred place of death and actual home death, we've done a lot of research now around preferred place of death and home death, and preferred place of death changes a lot as time goes on, and home deaths are very hard to achieve. The other thing in terms of achievements, I think is mentioned about research, and Patsy mentioned that, and we are involved with a study by the Mater and St Vincent's and a few other places. Gold Coast was involved, Royal Brisbane was involved, and what we're able to achieve is we've just finished recruiting our last patient to a medicinal cannabis trial, CBD versus placebo, for palliative care symptoms, which is great. And we're looking to evaluate that. In terms of top priorities going forward, I really think it's important to think when we've got this palliative care strategy is to look at this idea of models that may be working and how to expand that. And I was really interested in that. Seems to be an approach that was taken for Aboriginal and Torres Strait Islander funding, which I think is a great way of doing things. I think there's still a lot of inequity across HHSs. Obviously, people see that. We notice that in Brisbane, vast differences for us in terms of going across Metro North and Metro South. We're one of the few services that goes across two HHSs, and it really highlights the differences of care. Still very hard to get care for a lot of people under 65 that is needed. The other thing is this access to funding on the basis of activity and also evaluating programs that occur. So I think that's really important to be embedded in that, and basing around patients. Other things I think from a private point of view, but medical point of view is, and it's interesting what people were just mentioning about general practitioners is, and the, I guess, so that came across a bit from a few different people as a disengagement. And I look at something like QScript, which some people are aware of, which has got really good intentions and it's got some really good basis to it, but it'll only seek to disempower and disengage GPs from prescribing things like opioids, which is a huge part of palliative care practice. From that point of view, just a few other, I guess, highlights from the MARTA are things like the importance of integrating care. So integrating care between palliative care and oncology. And I think going forward, that's a really important model of integrating care into non-malignant illnesses. From that point of view, and expansion in satellite sites. So that's the other idea of, I think, about going with a strategy forward, is the idea of how do you expand slowly, successfully across various sites. So I was happy to leave that there so we can have time for questions.
Oh, I'm on. Oh, yes, I'm on. Philip, thank you. That was amazing and some really key points. I was nodding and writing down notes. So hopefully you've got some time to stay around. We've got Shyla, Shyla Mills. Just in case you didn't know, Shyla Mills is the CEO of Palliative Care Queensland and does an incredible job coordinating the team here and in terms and I guess extending the reach across the state and also across our great country of Australia. So Shyla is going to have a chat about our peak body and talk about what's been happening in the space of Palliative Care Queensland. So without further ado, I might kick it over to you.
Thank you very much. Well, thank you, everyone. And it's just been such a delight to hear and be a part of this important event today, hear all the amazing things that are happening throughout the sector. When we were designing this event today, we looked at last year's timing and we realized just how much extra activity is going on in the sector. So we had to increase the time. And even now we're getting a short time of running overtime. So it just shows how much activity is going on in this space. So a huge well done to everyone. So a quick update from PCQ. So we are the peak body of palliative care in Queensland. If you jump on to the next slide, a quick update. So we basically, our key focus is to raise awareness, build capacity, advocate and provide support. And we do this through two streams. So we look at the palliative care sector and how we work with the sector, and also directly to community with consumers and carers and the build compassionate communities there through our Queensland Compassionate Community arm. Over to the next slide. This is a big summary from our annual report, which summarises a bit of our initiatives and all the achievements that we've got from the sector in the past 12 months. So a lot of things happen in our sector, which is really important and a great way for us to work together. And I think a key thing is that the foundation and the glue for all of our work has consistently really been collaboration and working with a huge number of organisations, individuals, our members, amazing board members, everyone involved to really make this happen. So, the work that PCQ is achieving has been from everyone involved, from our staff to our volunteers and all those collaborations as well. So really be proud as a group of where the organisation is going and what it has achieved. Over to the next slide. So I mentioned at the beginning this great event that we hold each year, and then it rolls into an annual priorities document. These are our priorities that we published last year. And amazingly, if you go through them and you listen to what we've talked about today, every one of them we are addressing. We're not there yet. We haven't got to the perfect place in palliative care, but small steps in the right direction. And I think, today has just showcased how much activity is happening, but again, working together in the same direction. So the first one around funding and supporting palliative care to improve sector effectiveness and quality. You know, the additional investment going on in this space is huge. The second one around redesigning services and ensuring equitable access to services. Clinical excellence team, the private hospitals, the hospices. So many of you have just mentioned different stories today that's really working in that space. And Aaron's key discussion around Indigenous and First Nations work in this space is huge. The third one around working with community. You know, Anne doing all the kitchen table discussions there, the hospices who work directly and build compassionate communities, the work PCQ does in the community education space and ambulance wish program and other things like this. And the talks this morning, talking from Public Health Palliative Care International too. The fourth one about building capacity in the palliative care health workforce. Well, a workforce plan, which the government's working on at the moment, is a key activity that will build that workforce, and all the activities going on within the teams of extra staffing and extra supports in that space is really critical so that we've got a long-term workforce with the skills needed. The fifth one, looking at advancing research. Patsy gave a great example of what's happening in that space, showcasing activities. And then the last one, which looked at with VAD being on the radar, and like David mentioned, you know, our goal last year was to promote the role of palliative care in ensuring issues, including disaster planning and the deliberations regarding VAD. So ensuring palliative care was on the radar during these discussions, and I think it has been, definitely. So I think the sector really needs to be proud of what it's achieved, and great to sort of see that outcome. Again, lots more can be done, but it's great. It's small steps in the right direction. So just the next slide, over to what PCQ is doing. So what we're focusing on is working with the government at the moment regarding the current reform, which has been mentioned. So making sure that's going in the right direction. It's a fabulous investment and it's a really good start to what we need. We continue to do our Palliative Care Is campaign, which is about raising awareness about what palliative care is. Simple explaining this in 10 easy steps is a really critical thing that we've noticed with community. We have our True Choice campaign that looks at palliative care being a true choice. So what in addition can be offered in palliative care? The reform is a start, and then what else needs to happen? Ensuring that's really transparent, and we're working collectively with the other peak bodies around that space. And we continue our What About Chris campaign, which you might remember from a few years ago, and that is Chris. Chris could be any age, male, female, any location around Queensland, and everything we do in palliative care needs to be about Chris, because that's what the purpose of palliative care is. We're about working around our patients, their families, their communities as well. And we need to make sure we're all working in that same direction. And then finally, really, what have we learned? You know, so we're really proud of the sector, what's happening at the time. So collaboration, our sector is working together like never before, really achieving amazing things, and you're hearing that today. We've learned that we are valued as a sector. You know, David really emphasised that from the Health Minister in his address there. And the government and other peak bodies are working with our sectors, listening and responding, and it's so powerful, and we're really seeing some achievements. And I think the last thing is self-care. It's a marathon, not a sprint. You know, there's a lot of work involved. I think someone termed the phrase the other day of consultation fatigue. You know, there's a lot happening in this space, and we need to be aware that we need to be part of that consultation, because we need to see the outcomes that we've been asking for a long time. So self-care is really critical during this time. And so just finally, what are our top priorities in this space? So transparency of current funding, actual spend of what is being spent throughout the regions of Queensland, so that we can understand specialist, generalist spend in the space between different HHSs, what's actually happening, so there is clear and transparent funding. Then once we have that, then we can clearly define the gaps. What's the remaining needs and the funding gaps in the sector? And that's part of where the True Choice campaign continues. And then finally, ensuring that all layers of palliative care sector and the community are supported and included during this period of rapid change for our health and society at the moment. So just a quick overview from Palliative Care Queensland, and we can run into the Q&A now.
That's amazing. And probably one of the things that I've noticed over the years, just really looking at the connections and the collaboration, is that it's you know, it's a way forward, it's respectful, we can challenge each other, but we know that there will always be work to be done. So where there's work to be done, Palliative Care Queensland will be there working with you and beside you, for you. So we've got a couple of comments, haven't we, for Q&A, but also if anyone wants to type anything in, we still have Aaron Hoffman on as well, and David Harmer. Philip Good is there as well. So Sue, well, there's probably a lot of people, but just some key speakers. So is there anybody that has a specific question that we've got there?
Yep, so maybe for whoever is a speaker that is available, if they want to jump back onto camera. Yep. And so we've got two questions that have come through the Q&A. So one I will address actually to maybe David, just still online. So it mentions about, I like hearing there is a priority on workforce development and planning. I have heard this many times over the years, and I'm wondering what processes are in place to actually make this happen. Is it state funding, or is it down to each HHS? Will the growth be in all clinical areas, nursing, allied health and medicine? Usually the medical industry that grows first. So over to you, David.
Hi, Charlotte, thanks for the question. Can I just check you can hear me? I can't, my screen's kind of frozen, so oh, good. I think the question was, how is it being funded? The answer to that is the Department of Health's Workforce Strategy branch is developing the strategy in consultation with stakeholders from around the sector, and they've got a lot of good information already, you know, informing us about demand, about the existing workforce, where the gaps are and where we need to get to. So I think the answer to the question is it's fully funded by the department as, you know, part of our commitment to the appropriate design of the 171 million. This isn't part of the response to the question, but I'm very sorry, I need to let you know that I'll be jumping off in a few minutes. So, because I've got another commitment, but if there are any final questions for me, I can probably answer them before 3 o'clock.
Yeah, that's okay.
We've got your phone number, David.
That's good. Sorry.
So there's another question here from Ben talking about social work, and this is up in the Q&A area. So I'll just summarize it. Do you think social workers are well placed to champion the ACP process to the completion of the documents of advanced care planning documentation? As you may be aware, in Queensland, these documents can be forwarded to the Office of Advanced Care Planning for the healthcare teams to utilise through the viewer, and now non-government services health provider portals as well. I think there's not really, well, it's a big plug there for Office of Advanced Care Planning, and I don't think Alison's online, so I would have shot it across to her to answer. But essentially, I think what Ben's really raised there is really important about the broad people that should be involved in advanced care planning process, the great work we have in Queensland for the Office of Advanced Care Planning and tools like that, and the translation of the advanced care planning tools into clinical practice as well is really critical in the space. So we don't have any other questions come through that platform, but is there anything else you wanted to raise or anything you wanted to mention?
I probably want to, just with recognising when we were talking about research and Philip's contributions with colleagues at the MARTA, and I wondered whether, you know, you had any, you went through pretty quick, Philip, but, you know, just in terms of, you know, the way we're seeing interaction with people. We heard about the Sue, both the Sues from the community, but just how hard it or some of the changes that you've seen across with COVID and providing care and where we might be able to go moving forward. I just thought that opportunity to see how services can, you know, be prepared, particularly those that are providing the primary care, the palliative care.
Thanks for that. Well, I think interestingly, we have done a little bit of research around COVID and the effect on community palliative care versus inpatient palliative care, and it certainly has changed our dynamic. For example, there was much more telehealth and video health at the time, and the activity increased in community. And interestingly, that our activity inpatient unit didn't actually decrease, which was what has happened overseas. From that point of view, we have had challenges, just like people described about visitors and visitors from interstate, and I think that will continue to be an issue. And I think we've all had to put in place processes. It's been fascinating to me, the whole idea of risk. I think everyone has a different idea of risk, and at the beginning, people, well, we found it varied from the risk, very risk adverse, to actually prioritizing. I think it also, I mean, it was a good example to me about the variation in practice. So there was this thing about people visiting into hospitals and into hospices, palliative care units. And you may think there was a clear direction from the CHO, and it was a very broad direction, and people really took it differently. And I think it highlighted the fact that, for example, we would have people refer to us at St. Vincent's who they would say they're allowed to have this at our hospital, and we would say, well, they can't have that at this hospital at the moment. And they would say, but we can have it here, so why can't you have it there? Versus other hospitals where people would be able to get very few visitors, but we could give them a lot more visitors. I must say, none of us would have liked the COVID to go on for as long as it did, but personally, in the end, for us at St. Vincent's, we actually had a very good visiting policy by the end, but unfortunately it did take, 12, 18 months where we got that. And that's also a lesson of how long things take to come into practice, I think, from that point of view. So I think it's an opportunity to think about how we do models, think about how things go forward for the future.
Fantastic. Thank you for that.
Yeah, really well said. I think there's a lot of work going on, I think, in the media down in Melbourne at the moment around the increase in palliative care patients in the community setting in the COVID times. Yes. So lots of comparisons to be done across the national front as well about the impact of COVID. And I think all the states everywhere internationally will have a different journey during the COVID period. So for the interest of time, we might not be able to do any other Q&As. Thank you so much for everyone staying on board, and yeah, just amazing speeches today, and great to hear from everyone. Hey, Mark.
Brilliant. Honestly, so proud. I think this is, when people talk to you about why you choose a path, who wouldn't like to be working with great humans, caring for other humans? I think that's the answer. So in terms of our concluding comments, it's always hard to say goodbye, but we'll say until we see you next time, particularly on the 11th of December. You might be thinking, I haven't organised anything. Well, let me tell you what we've got up our sleeves for you. We have the Ambulance Wish Gala event that is something that needs to be well supported, I think, given you would have seen the stories. And if you haven't, please make contact and we can link you in to see some of the wishes that we have granted. But this fundraising gala is going to be really exciting. It's on the 11th of December. There are, as I said in the earlier session, there are competitions with who can get as many tables as possible. We're not going to give names, so don't be one of those last to register. We'll be there, won't we? John Haverack, Sister Haverack will be there. So John and I will be hosting or emceeing the event. The Palliative Care Queensland and behind the scenes colleagues and our sponsors make us look good. So we really want to make you look good too by sitting at a table. We really wanted to thank everyone who has presented today for preparing your talks and sparing your time for this really important event. We thank you to the wonderful staff that made today happen. And I just really do want to, if I could get Naomi and James just to come to the camera to actually show who has been working fearlessly behind the scenes, making us look good. So we have Naomi, I can't see you, and there you are, look, so fabulous. Okay, thank you so much for your contributions.
As well as the many other
yes,
offices.
I was going to say, and we've got our colleagues outside who are just working so hard to get this happening. So thank you. Thanks again to Palcare Software for sponsoring this event. We really appreciate the sponsorship, and to our other partners and to our members. And if you're not a member, come and, I know there's a lot of, demand, but there's a lot of contributions you can make. So please, and we can learn from you. And that this event is going to be made available to all of you as a recording. And again, the presentations will be available in PDF form. So probably 3 months is what it will be available for in terms of the recording. The other point that we had to make was, I'm just looking here to make sure, evaluation. Please send us your evaluations. I think that's going to be key for us in terms of, we've been writing down things, about what we hope to achieve for next year. But what comes out of this is the work that will support you to do your work. And that's really the whole purpose. So please let us know what you think, what you thought, if you've forgotten anything. And I'd like to encourage any further questions that you might have that you didn't get to ask to come via the hello@PCQ email that I'm sure is somewhere. Yeah,
on our website.
It's on our website. Yeah, so go and find that. It's up the top of the list when you get there. I think, have you got any closing remarks?
No, just a huge thank you to everyone who, we know how busy everyone is. We know how it's ramping up to the end of the year at the moment, and just all the consultation going on, all the work that's happening at the moment. So really just appreciate everyone for taking the time today to attend this session, who watch this in the future online. Really appreciate that. And also to all these amazing speakers. And to Marg as our lovely and wonderful presidente of the organisation, and just all the board and everyone that does all this hard work, and the staff.
You really are a fabulous group of humans out there, and thank you, and give our best wishes to your to our colleagues, your extended family, and also to your clients. So thanks again, and have a wonderful evening, and we'll see you on the 11th of December. Bye.